Good morning, everybody, and a very, very warm welcome for everyone who's phoning in from around Melbourne, Australia, and indeed around the world. It's delighted to have you all here with us this morning, here in what is a very strange Melbourne, a very strange Victoria, and indeed a slightly strange world. We're grateful for all of the opportunities that we have with the internet and technology to still allow us to run this incredibly important patient and family forum, which we've all registered for. And I'm really pleased to report that as of last night, registration was just over the 200 participant mark, which is a fantastic accolade for all of the hard work that's gone in by the MRB and organising committee, all of your commitment and all of the networks that exist out there who are interested in making bone marrow failure a thing of the past. We are meeting from a range of different locations, and as I've said, we're based here in Melbourne. And I would like to, as is always appropriate and just simply good manners, to thank the people who make it possible for us to meet, which are the traditional owners of the land on which we are meeting. Now, ordinarily that acknowledgement would occur when we were physically in one place. And so I'd like each of you, if you wouldn't mind, just taking a few seconds to acknowledge the traditional owners in the place where you are for the opportunity to use the space in which you occupy for this activity today. So I do acknowledge the traditional owners on the land on which we meet, the Wurundjeri people, for those of us here in Melbourne. And I pay my respects to their elders past and present, and to any other members of traditional owners who might be with us today. We do have quite a lot of business to get through today. I would like to just take a moment to thank our sponsors, who without their generous support wouldn't have made even this somewhat virtual meeting possible. And so our thanks to the Royal Melbourne Hospital Foundation for their support of this meeting, and of course for the support of Carmen, not just for this meeting, but for all of the support that they give to MRV throughout the year. We are very, very appreciative of all of their support and acknowledge their commitment to our cause. There will be some housekeeping announcements to make before we get into the main agenda, but if you will just allow me to make a few personal observations before we start, before we get into those housekeeping announcements. Now, I've been thinking about this a lot, of course, over many years in my involvement with MRV and before that, in patients who have bone marrow failure syndromes. And I would like us all just to take a moment to reflect on why we are all here. 200 people have joined us today, and we all share something in common. And that is in some way, either directly, profoundly, and permanently, or perhaps more recently, we have been touched by bone marrow failure as a personal trauma, as a professional challenge, or as a research question for which we need increasingly better answers. And all of us stand to learn from each other today, whether we be a clinician, whether we be a researcher, but most importantly, whether we be a family member or patient who has been affected by one of these conditions, either now or in the past. When I spoke with the Rewalt family, Joe, Fiona, Alex, Nick, and their supporters at the very inception of MRV, a very important question was asked, which is, where should the as yet to be realized, but has turned out to be substantial fundraising be best applied in order to make bone marrow failure less of a troubling, traumatic, and terrible cluster of diseases. And I gave that some consideration, and we came down to a conclusion that those funds would be best directed, at least initially, to research. And I was thinking over the last few months about that word research. And research literally means to look again, to have another look, to come at a problem from a different direction, to reconsider our assumptions, to consider all the things that have gone before and see if we can make the things in the future better, to get people thinking collectively and looking at things collectively. And that's exactly what MRV, and through MRV, the CRE and the aplastic anemia registry have undertaken to do. And we'll hear some of the advances through the presentations that we're here today. So I do want to acknowledge that we all are here to learn from each other equally, to look at the problem collectively, and to not rest on previous assumptions, to research the problem. So with those thoughts in mind, and a very warm welcome to you all, there are a couple of housekeeping things that I do need to attend to before we get on to the first session. This is a webinar. We are meeting virtually and remotely, but interaction is critically important to the success of today. And so we encourage questions, and thanks to those people who forwarded questions ahead of the meeting today. But there is an opportunity to ask questions through the webinar technology. Some of those instructional slides have been playing just before we started, but just to go over them again, there's a Q&A function at the bottom of your screen. You can click on that icon and type your question in. We are actively viewing those questions as they come in, and we will be endeavoring to answer all of them at the end of each of the sessions. During the question and answer session that's set aside at the end of each of the talks, each of the sessions of talks, there is a hand raise function. So if you do that, we will be looking for people raising their hands. So you don't have to type in a question. You can ask a question live if you wish. And the hardworking team back in the MRV office will be ensuring that questions are able to be asked live if that is the way that you're comfortable in doing so. It is a lot of people on today's webinar, and we're extremely grateful for that, and buoyed and encouraged by the support that this webinar and session is being supported by all of you. So we may not be able to get to everybody's questions, but we'll endeavour to do so. So feel free to ask questions at any time during the sessions by typing them in, and then during the Q&A sessions by raising your hand, and we will attempt to get to as many as we can. We apologise in advance if we're unable to do so. So with all of those opening comments and bits of housekeeping and acknowledgement undertaken, we will get into our first presentation. So Anthea Greenway, Dr. Anthea Greenway, is an extremely experienced hematologist, pediatric hematologist, but he's also spent time in the adult diagnostic laboratories in hematology, and it was a very great pleasure for Anthea and I to spend time together as the young consultants at the Peter MacCallum Cancer Centre while she was doing some of her training there. But she's moved on from that, and she is a paediatric hematologist at the Royal Children's Hospital and the Monash Medical Centre in Melbourne. She has a wide and deep interest in a whole range of different hematological conditions, including disorders of hemoglobin. She fundamentally drives a service that's important for transplantation and the therapy of diseases in paediatric hematology, known as apheresis, and she's been an absolute superstar in getting that service up to the level that it is currently present for children here in Victoria. And she completed a clinical fellowship in hemoglobin disorders at Duke University in North Carolina. We're lucky to have her back in Melbourne at the Royal Children's Hospital, and I'm very pleased to introduce her as she gives us her insights into the identification and diagnosis of bone marrow failure syndromes as they present currently. Thanks, Anthea.
Thanks, David, for those very kind words. It's my absolute pleasure to be here this morning. Just going to share my slides. Making sure that, there we go, great. So good morning, everyone. My name's Anthea Greenway. I'm a haematologist at the Children's Hospital and Monash Medical Centre, as David has mentioned, and it's my great pleasure to really set the scene for our symposium this morning. So really, the tasks I've been set with is just to introduce the topic of bone marrow failure, to start us thinking about some of the causes and some of the problems that this causes for patients and families, to think about how we work through the process of diagnosis, with a brief introduction to some of the therapies that we may need to treat this condition. So just taking a step back in terms of what is bone marrow. So our bone marrow is a honeycomb-like structure inside our bones, predominantly in the long bones of the body. So that's in our legs, in our pelvis, and in our skull. This is a really active site of production of the stem cells. And the stem cells really are the cells from which all the cells within the blood are derived. So the stem cells produce our white blood cells, which make lymphocytes and neutrophils, which are important for infection and immunity, our red blood cells that carry oxygen around our body, and our platelets that are really important for allowing us to form a clot and to stop bleeding. And our bone marrow is really busy and active, particularly in infants and young children, and as we age, it's replaced with fat and scar tissue as part of that ageing process. So what we need for a healthy bone marrow is a number of nutrients that are really important for cell production. So these include things like iron, vitamin B12 and folate. We need a good blood supply to the bone marrow. We need the genetics or the instructions that control the manufacture of the cells. The absence of scar tissue and damage is important to allow our bone marrow to function. We need normal background immune function. We need the absence of infection, so a number of important infections that can really influence the way our bone marrow works, and the absence of drugs and toxins and radiation that can significantly impact on bone marrow function. So the definition of bone marrow failure is really where our body is unable to continue to produce the blood cells that we need to support our normal activities. I think it's really important to think about this concept that we need ongoing renewal and replacement of our blood cells, which all have a limited lifespan. So our red blood cells usually last about 120 days, our white blood cells or neutrophils last 5 days, and our lymphocytes, which are important for viral infections, last a little longer, so weeks to months. Our platelets, which are the cells preventing problems such as clotting, last about 10 days. So what are some of the symptoms and signs that may come to me in the clinic when I'm seeing children with problems with their blood count who may be sent in from a range of sources, including their GP? And this is similar symptoms we see across adults. So the low hemoglobin or the low red blood cell count causes anemia, and this will cause tiredness and fatigue, difficulty with exercising, shortness of breath, and in children particularly, problems with appetite and poor growth. With our white blood cells, the neutropenia and the lymphopenia cause increased risk of infection, but also some other problems, particularly issues with mouth ulcers and bleeding gums. And our low platelets cause problems with bleeding, bruising and blood noses. Some of the other signs and symptoms that are really important to me when I'm seeing a patient for the first time might in fact relate to the underlying cause of the bone marrow failure. So there can be some typical facial features or facial changes, some bony changes, lesions on the skin, or problems with the liver and the lung that may well help me to recognise some of the underlying causes of bone marrow failure. When we think about the causes, really, although we do often separate these into age of presentation, this is really a disease of spectrum. So some of the diseases we have onset in childhood, and these are related to what we would call the inherited bone marrow failure syndromes, which are diagnosed in about a third of children presenting with bone marrow failure. These conditions have a strong underlying genetic diagnosis or underlying sort of genetic mechanism. It's really important to think about these conditions because knowing that there's an underlying genetic cause has significant impact in terms of how we may treat these conditions, but also how we think about the other implications for families, so other family members that may well be affected. In our older patients, we have this concept of the condition of aplastic anemia, which is a broader group of conditions, which is obviously often where we can't find an underlying diagnosis such as those congenital syndromes. So this is a bigger group. A number of the disorders in this sort of category really we think have an autoimmune basis, and that's based on the fact that many of our therapies are targeted towards immunosuppression in terms of improving outcomes for patients with aplastic anemia. Some of the adult diseases in this group relate to disorders that we call clonal, where we have a small group of cells that become abnormal within the bone marrow itself, and that can include things like PNH and myelodysplasia. Across the age groups, we again have those issues I mentioned, so things like radiation, toxic medications and infections that can affect both children and adults with these conditions. And one of the really important things we've increasingly recognised in the last few years is that we do have a number of young adults and adults across the spectrum who in fact do have underlying congenital or inherited bone marrow failure syndromes, but don't present till the adult years. And so it's really important for us to think about that in adult patients presenting with these syndrome or with this condition, to make sure we're excluding those so that we can ensure that we're providing appropriate genetic screening and counselling for families. There will be a number of talks following mine that really talk about the genetics of these conditions, so I won't go into any detail other than to say and to sort of reiterate, as David mentioned, some of the fantastic work being done by MRV in terms of the explosion of information we have in the last few years about the genetic basis for these conditions. And really you can see from this slide, which is sort of a schema of the complexity of some of the genes that are involved, but really our interconnected pathways that lead to bone marrow failure are much better described now with all of the research that's going on. So I was just going to briefly mention a couple of the syndromes before we briefly talk about diagnosis. So Diamond-Blackfan is a congenital bone marrow failure syndrome, which is reasonably rare, but presents in very small children, so babies on average 8 weeks of age up to about 1 year. And as I've mentioned, many of these conditions have other changes that we can find on examination testing that are important to know about, so that I can make sure I'm looking after all the aspects of this child's condition. In about 50% of cases, this is an inherited condition, and so again, looking back at families and other brothers and sisters will be really important. And this disorder affects the ribosomes, which are the protein factories in our cells. Another condition in this age group group of congenital bone marrow failures is the Shwachman-Diamond syndrome. This is a bit more common, but has a much broader spectrum of presentation, so smaller children to middle childhood. And patients with Shwachman-Diamond often have significant neutropenia and growth failure, but this condition also affects the digestive tract, so making sure we're focusing on looking after and diagnosing those complications is really important. Fanconi's anemia is again a rarer condition, but again affecting middle childhood, and this is a chromosome breakage syndrome where our chromosomes are much more fragile and at risk of repeated episodes of damage during life. It's commonly associated, much more commonly associated with other changes to the body that we need to be aware of when we're seeing patients with this condition. And dyskeratosis congenita is one of our congenital syndromes, but often not necessarily presenting till sort of teenage years and early adulthood, more common in males, and again has some classic features that we might find in examination, including changes in the nails, the skin and the tongue. I'll just briefly mention paroxysmal nocturnal hemoglobinuria, which is one of our adult conditions associated with changes, a genetic change that affects the red blood cells and makes the cells more fragile to break down, but then goes on to cause bone marrow failure syndromes, including aplastic anemia. So you can see from this exhaustive list that making the diagnosis of bone marrow failure takes sort of careful consideration for the patient, the symptoms they're presenting with, and the findings that we might find on careful clinical examination. And then what we do next is really focused around trying to determine whether one of those underlying syndromes is present. And in the absence of finding a syndrome, or importantly, in the absence of finding an underlying genetic cause, we often will classify the condition as aplastic anemia. So really, there's a range of blood tests, bone marrow tests, genetic tests, and then a number of tests that are focused on looking at some of those end organs that I mentioned, so liver and lung particularly, but x-rays and cardiac investigations to determine which parts of the body may be affected. And really, we stratify or prioritise these tests based on the age of the patient and the other findings that we may see on clinical examination. So the bone marrow biopsy is a really important part of diagnosis, and as you can see from this picture, this is how we do a bone marrow test in a small child, where we're putting a needle into the same sort of technique for an adult patient, but we're putting a needle into the back of the hip to take out the bone marrow to have a look. And just really to highlight what we see under the microscope. So on the left, you'll see a picture of a child's bone marrow really busy making all of those stem cells that will come out into the circulation to form our blood. On the right-hand side, this is a bone marrow sample from a patient with dyskeratosis congenita. So you can see far fewer cells present and lots of fat cells, which are like those sort of air-filled spaces you can see. So just to briefly finish thinking about treatment for patients with bone marrow failure. So in the first phase, much of our treatment is focused on supportive care. That's making sure that we provide the cells that the patient can't produce themselves when the bone marrow is not functioning normally. This will include things like red blood cell transfusions commonly, but also things like platelets to stop bleeding. We use medications such as antibiotics, antifungals and antivirals to really try and prevent infection, which is one of the common complications of aplastic anemia and bone marrow failure. And then we think about medications that might again help us with some of those symptoms, such as particularly bleeding. We need to manage some of the complications from our treatment. So red cell transfusion can cause a problem with too much iron in the body. And so thinking about how we might help patients get rid of iron is an important part of their ongoing care. We may be able to use particular growth factors. So TPO is a growth factor that helps us to make platelets and stimulates platelet production, and that's been very effective in across the spectrum of patients with aplastic anemia and bone marrow failure. And again, aggressive and early treatment of infection is a really important part of care. Thinking about some of those other organs that may be involved, particularly the gastrointestinal tract, is important. And for all patients, having a good relationship with the treating haematologist and the treating centre to make sure they're having regular blood tests. For children, carefully monitoring growth and development, monitoring the bone marrow as needed is really essential in terms of managing their condition. Other treatments may well be related to the particular cause, and so we know for some of those genetic conditions that I alluded to earlier on that are particularly related to DNA repair and DNA damage. In some of these conditions, treatments such as steroids or androgens, things such as testosterone, which can help with the longevity of cells, may well be applicable, or very specific newer agents such as eculizumab or monoclonal antibodies for the adult condition PNH. But for many of our patients in the aplastic anemia group, where we don't find an underlying genetic cause, we may end up using medications such as immunosuppression, which really speaks to that mechanism I mentioned previously, where we think some autoimmunity may well cause some problems with the bone marrow. And we have a good response in many patients with immunosuppression, but for many patients, repeated courses will be required and ongoing monitoring is essential. And the last treatment I'll mention is bone marrow transplant, which will be discussed in a later session today. I'll finish there. Thank you. Thanks, David.
And thanks to you, Anthea. Hopefully you can see me again. And we will hold questions to the end of this session, but I do see questions coming in on the Q&A, which is fantastic. And there will be an opportunity to ask live questions. So I do want just to move on and thank Anthea and introduce Lucy Fox as our next speaker. Some of you will know Lucy extremely well. I'm very fortunate to know Lucy through our work here at Peter Mac and Royal Melbourne Hospital, and through her work as a research fellow, specifically in the genetic and genomic causes of bone marrow failure syndrome. Lucy is a haematologist. She completed her training couple of years ago, and she's now undertaking a Doctor of Medical Science degree through the University of Melbourne, specifically in this field, which makes her extremely a valued member of our team. She has been a recipient and still is a recipient of support through MRV, and as are many of our speakers today, and we're grateful for MRV's support of these upcoming young and developing stars of bone marrow failure research. I won't go on with any further of her introduction because it's long, lengthy, and you'll see her the quality of her speaking while she is doing her presentation. But as Anthea mentioned, one of the greatest growth areas in bone marrow failure syndrome has been genetic testing, and we really look forward to Lucy's presentation in this important developing area. Thanks very much, Lucy.
All right, thank you, David, for that introduction, and it's a real pleasure to speak to you all today about this topic, which I've become really immersed in over the last couple of years. So many advances have been made in genetic testing in blood diseases in recent times, and we're really seeing that they are being translated into meaningful benefits for patients and their families. There's still much to discover and improve upon though, and every day we focus on how we can do this. So with the genetics focus, I'm going to tell you what I mean by the bone marrow failure syndromes. And I'm going to take some time to explain the difference between inherited and acquired mutations, because both of them are relevant to patients with bone marrow failure syndromes. And we've had some very insightful questions about acquired mutations submitted ahead of time. And I'll also explain to you, not in too much detail, don't worry, how we go about hunting for mutations, and once we find them, how we convey this to your doctor. So as we've heard from Anthea, the bone marrow is the blood-making factory. It's the organ that produces those red cells, white cells, and platelets that we need for everyday living. And on the left there is a healthy cellular bone marrow capable of churning out those blood cells that we need. And on the right is an empty or a hypocellular bone marrow that just can't produce those blood cells. Prior to me explaining the genetic testing that accompanies these diseases, it's important for me to take the time to explain to you exactly what I mean by bone marrow failure and why we consider them under the same umbrella. So firstly, we have acquired aplastic anemia. You might also know it as idiopathic aplastic anemia. And we've heard from Anthea, this is an immune-mediated process that is not considered to be an inherited disease. Secondly, we have the traditional bone marrow failure syndromes, diseases that we've known about for many, many years, but in which huge advancements have been made in how we can genetically diagnose these patients in recent times. And these disorders are considered to be inherited, or the other name is germline. And finally, we have the new kids on the block, if you like, this group of people with an inherited predisposition to developing hematological malignancy or blood cancer. And by this, we mean, we're mostly talking about developing acute leukemias and the closely related disorder, myelodysplastic syndrome. Again, these are considered to be inherited conditions. So I've called that group 3 the new kids on the block because really we've only known about them for the last 10 years or so, and some of them really only in the last 6 months. But that doesn't mean that these diseases haven't been causing real problems long before that. And I know that there are some families in the meeting today who tell us stories of leukemia going back for generations. And in some cases, we can finally give them a reason for these devastating experiences. And what we also want to offer is real hope for better outcomes for these families today and for future generations. So why do we lump all of these diseases together under the bone marrow failure syndrome umbrella? Firstly, patients can present in the same way with symptoms due to low blood counts. And secondly, these diseases can have that same hypocellular or empty appearance when we look at them down the microscope. So the doctors who manage these disorders need to have all of these things on their list of potential diagnoses when they're trying to pinpoint the diagnosis. We lump them together because some aspects of the treatment are the same. As Anthea said, a stem cell transplant can be used to treat all of these conditions. And a final unfortunate thing that ties them together is an increased risk of developing a blood cancer. This risk is relatively small in acquired aplastic anemia, but can increase in the other conditions and really varies, the risk varies according to what the underlying gene is. So I want to take some time now to explain inherited or germline mutations, and then I'll move on to acquired mutations. So inherited mutations underlie the traditional bone marrow failures and the predispositions to blood cancers. We have 2 copies of all of our genes, one that we inherit from mum and one from dad. And there are multiple avenues by which genes can cause problems in the bone marrow failure syndromes. There are dominant mutations where you only need one faulty copy of a gene to cause disease, and this includes GATA2 and some of the telomere disorders. And there are recessive conditions where you need 2 faulty genes in order to cause the disease, and this includes Shwachman-Diamond Fanconi anemia. A third mechanism is where genes are encoded on the X chromosomes, such as DKC1, and Anna, our genetic counsellor, will talk to you a little bit more about this in her talk. But I also want to mention this thing called de novo mutations, because this is a term that we use a lot, and they're actually something that we see pretty frequently. And the terminology, again, can be a little bit confusing. This happens when neither parent has the mutation, but a genetic change happens early in the embryo development. So it's present in most or all of the cells of the baby. And so will be in their eggs or sperm as they grow up. And so it can be passed on to future generations. And so we call these inherited mutations, even though they haven't come from mum or dad, and that can be a little bit difficult to get your head around. So this is an example of the kind of screen that we spend many hours looking at each day. This is how we analyse our genetic information, and this is an example of one patient. Our scientists have taken the DNA out of patient cells and over some days obtained the genetic sequence of the gene of interest. And the computer presents to us what it thinks is the most relevant information. And the many variants are identified in this one patient. Nearly all of it's harmless. It's part of the wonderful diversity of the human race, but some of them are problematic. And so starting with number 1 here, the computer identifies which gene that it's identified a potential problem in. Over at number 2, it tells us in detail the specifics of the genetic change. In the case of the top line here, there's a change at position 699 of the Elaine gene, and it's a C to an A at that position. Over here at 3, we tick those changes that we think need a closer eye on them, and we do something called curate them, which is get the evidence for them. Have they been seen before, etc. And then number 4, we take all that evidence and we classify the mutation. Do we think it's harmless, or do we think it's disease causing? And if we think it's disease causing, then we decide to report it. And you can see here that we tick that one particular gene to report. And this is the report for that same patient. This is a girl presenting with severe congenital neutropenia, low white blood cell count. So we found a mutation in the Elaine gene, and that position 669. This occurs in the setting of severe low white blood cell count, so that fits this girl's clinical picture. It's dominantly inherited, meaning that we only need one bad copy to cause the clinical picture. And we classify this as pathogenic or disease causing. And we provide the evidence for this classification below. And then we give the treating team some information in this summary box up the top, telling them that we've found a genetic cause for this patient's severely low white blood cell count. And importantly, that she needs the services of someone like Anna, speaking next, to help that patient make sense of what this means for them. So why is knowing the specific genetic mutation helpful? Well, it can confirm the diagnosis, and sometimes people have been on what the Americans call a diagnostic odyssey, several years of painful ill health and not really understanding the reason why, and this can put an end to that uncertainty. It could provide prognostic information. And it also means that we can easily, quickly, cheaply test for that mutation in other family members once we know exactly what it is. And further to that, we can then check that a potential stem cell donor from within the family doesn't have that mutation prior to them donating their stem cells. It tells us the chance of that patient having a genetically affected offspring. And further to that, it permits that patient to consider whether they want IVF and pre-implantation genetic diagnosis or prenatal diagnosis. So I'm going to move on to acquired mutations now, because I know many of you are interested in this. So acquired mutations, also known as somatic mutations, can occur in all cells all throughout life. And in fact, the development of small abnormal clones of acquired mutations in the blood compartment can be seen in many elderly people, and we call this clonal hematopoiesis. And many of these mutations are not significant, but in some people, blood cancer develops. So I want to stress to you that we are still learning about what acquired mutations in the bone marrow failure syndromes mean. They're really common in acquired aplastic anemia, and they're also seen in many of the inherited bone marrow failure syndromes or predisposition to blood cancer. So I'll give you some examples about what we've seen. So, for example, an aplastic anemia patient, we've seen a patient with a small DNMT3 mutation sitting there at 2 or 3% that's remained stable for many years, not causing any problems. On the other hand, we've seen a patient develop multiple mutations on their way to developing acute leukemia. A disease where we really are not finding out quite a lot about acquired mutations is Shwachman-Diamond syndrome. And we now know that these patients can develop TP53 mutations, and they can have just one stable mutation again for many years. But what we now know is that they can get a second hit in their other TP53 gene, an acquired mutation, that can another acquired mutation that then can accompany the development of leukemia, and that can be quite devastating. GATA2 mutations GATA2 patients can get particular mutations in ASXL1 and ZBP1 on their way to accompanying leukemia, so we try to look out for them. And finally, DDX41 patients, most often, as they're getting, if they're going on a leukemia path, they get again a second hit in their other DDX41 gene as leukemia develops. So here is a recent article from the Dana-Farber Cancer Center in Boston. And I've highlighted this sentence here that talks about how we don't really have a good understanding about the link between these acquired mutations and the development of leukemia. I've highlighted the very recent date here to you to indicate to you that it's a hot topic and we're still learning about it. But what does this mean for patients today? What do we do for patients with bone marrow failure here at Peter Mac? Well, it's very patient and disease specific. And I'll tell you about what we think we know. So in patients with an inherited predisposition to hematological malignancy, we are testing a blood or a bone marrow sample every 6 months for development of acquired mutations. I stress that it's not based on published evidence, but there is rationale for doing it. And there's probably not published evidence for doing it because these are only really new conditions. So we need to gather data about that. I've said to you that Shwachman-Diamond syndrome is important from a TP53. TP53 mutations are very important in these patients. And we've got recent evidence that TP53 mutations should be looked for. So we will do it in a blood or a marrow sample every 6 months. So if you're a Shwachman-Diamond patient, please don't be upset if your haematologist doesn't know about this or do this for you, because as I said, this is really hot off the press information. But like I said, we do have emerging evidence to check for it now. And so I'll show you my email address on a later slide. And if you think that this hasn't been assessed for you, I can help liaise with your haematologist about how we can go about testing for that. For all other diseases, acquired aplastic anemia to the other inherited bone marrow failures, the jury's really still out about how often to test, and when we see a change, what that actually means for that patient. So we need to be very cautious about these tests. And it's the focus of many research studies. It's reasonable to request a test for looking for acquired mutations if something's changing in that patient, whether their blood counts are declining or something else is going on, such as we've picked up an abnormal clone on cytogenetics, such as a monosomy 7 there. So I'm sorry, I don't have time for a summary slide, but I'd like to finish by thanking both MRV and Melbourne Genomics, 2 groups who have very generously supported our genetic testing efforts over the last couple of years. And the entire molecular haematology team at Peter Mac, a very highly skilled group of scientists and clinicians who really dedicate their days to obtaining truly world-class genetic results. And finally, to all of you patients and families from whom we learned so much, you were so generous with your stories and often your samples. And this goes a long way to help those grappling with diseases currently, but also all those to come in the future. And that's my email address if you have any questions. Thanks, David. I'll hand back to you.
Thanks very much, Lucy, and always a incredibly insightful and hugely uplifting talk, because really for all the people on the call and on the webinar today, I want people to be assured that the research that's been undertaken in Australia and is largely supported by MRV and some of those really other important funding agencies such as the Genomics Alliance really are putting Australian research at the very forefront and the cutting edge of bone marrow failure syndromes. And all those people that were on the acknowledgement slide, I couldn't agree more regarding their dedication, commitment, and really grappling with a rapidly evolving field. There have been some really important questions coming through the Q&A as Lucy's been talking, and I promise that we will get to them at the end of the session. I do want to just move on, if we can, to the last speaker in this session, Anna Jamolovitz, who is a genetic counsellor. And as you would have already heard from Lucy, the area of genetics and genomic analysis in bone marrow failure syndrome is rapidly evolving. And one of the really key elements is to take that information and give good advice to families, good advice regarding the diagnosis, the prognosis, and how other family members may be affected. And that's really where highly qualified specialists such as Anna come in. She's a genetic counsellor here at Peter Mac, and really importantly is a key collaborator and contributor to the Embrace study, which we'll hear more about later on in the day, which is an MRV supported clinical trial that incorporates genetic testing in bone marrow failure syndromes. So thanks for joining us today, Anna, and thank you for your presentation.
Thank you, David. Just go and share my screen now. All right, can everyone see that okay? I hope so.
Thank you.
Great. Well, thank you, everyone. So yes, my name is Anna, and I'm a genetic counsellor at the Peter Mac Cancer Centre, working within molecular haematology. Thank you all for joining us this morning, and a special thank you to all our speakers as well, especially the individuals who will be sharing their experiences with bone marrow failure today. I just wanted to say, I know it can be very hard to do that, but it is very important, so a big thank you. My talk today will be talking about the process of genetic counselling, as it isn't an area that a lot of people are familiar with. As you've heard so far, it is quite a new and emerging area. So firstly, a question I get asked a lot, and I have stopped taking offence to it, is what is a genetic counsellor? What do you do in the team? So genetic counsellors are allied health professionals, usually with a master's level degree, and we work in hospitals and increasingly in private clinics as well. So working with genetics doctors and other specialists such as haematologists to provide care to patients with genetic conditions. So genetic counsellors have a training and a knowledge in genetics, but also an understanding that receiving a genetic diagnosis can have a huge impact on an individual. So we do have training there to help provide that ongoing follow-up and that support during the time of diagnosis. The next most common question I get asked is, what is genetic counselling? So this refers more to the process of providing information about the genetic condition and also that aspect of providing support. So I guess it is important to know as well that other specialists do provide genetic counselling or aspects of it. So genetic doctors and haematologists who talk to patients about the basis of their condition and help facilitate genetic testing for them. So the process of genetic counselling usually does involve several appointments, and through that we hope that the patient and their family learns more about the condition. So what specific type of bone marrow failure that they have, how did it come about, which Lucy and Anthea have touched on before, and I will go into a bit more detail about how that can happen. We do also organise genetic testing for people, so that's an important aspect, but not everyone ends up having genetic testing as well. So there's a discussion around management options for the person, but also screening for other family members, especially if they don't have symptoms of the condition as well. And some talks that we can have with people too about their family planning options if they are concerned that they have something that they might want to pass on. So I guess all of this to say that we do want people to have an informed decision that they make at the end of this process, feeling that they have got all that information. And then the important aspect as well is providing that support. So whether that be linking with support groups such as Maddie's Vision, or with more specific referrals if people do need additional support, mental or physical health support, and being there as a port of call for follow-up in the future. I also wanted to include this slide about what genetic counselling isn't. So some people, I guess, might be concerned coming to us that, you know, we will tell them that they need to have genetic testing and that they'll be forced into that. And obviously there are benefits to genetic testing. We wouldn't be offering it if we didn't think that there were some benefits. But we do want to acknowledge, as I said before, that potential impact. And we want to work with people to make sure that they're supported through that process. Genetic counselling also isn't psychoanalysis, so people are not coming into appointments for that aspect. And it isn't necessarily a long-term counselling relationship either, but that's certainly something that we could help you organise if you needed to, so ongoing contact with a psychologist or counsellor. If you felt that you needed that ongoing support. And we do things like liaise with them to let them know a bit about your story, so you don't have to start from scratch, sort of telling them all about that aspect. So just before I go into answering some of the questions that I get about how genes are passed on, it's usually helpful to give a bit of a genetics lesson just so people are on the same page there, and you've heard some bits and pieces already. But essentially we're made up of millions and millions of cells which all contain our DNA, and you can think of our DNA as sort of like the instruction manual to make a person. So it's made up of these individual letters, and these are the letters that form genes. And your body reads these letters or instructions and it does something with them. So whether that be deciding things like on what hair colour and eye colour you have, through to important instructions about how our bone marrow might function. And what we know is if you have certain spelling changes in certain genes or instructions, that can cause the body to not do something as well as it should. So we've heard a little bit about these types of inherited bone marrow failure conditions this morning. So these are some of the ones that we see in the clinic, but as Lucy said, there is new research that's always emerging, and we are always adding to this list. So in terms of how genes are passed on, there are a few ways that can happen. I'll just cover off two, I guess, the most common ones that we do see, but there certainly are others. I also want to excuse the American spelling on this slide. I didn't realise till the other day, but it is a nice clear slide, so I'll still use it. So with most of our genes, as you've heard before, we have two copies of them, because we get one from our biological father, one from our biological mother. And so the way that some genes behave is in this autosomal dominant pattern. So having a fault or a mutation in one copy of our genes is enough to either cause a condition or predispose you to developing a bone marrow issue. So if someone has a particular condition, like the father in this case, they have this 50-50 chance of passing that on to their children. So they're either going to be passing on the working copy or the copy with the fault in it. Now, something Lucy alluded to a bit earlier about where did Dad get his copy of this faulty gene? So this is where genetic counselling can come in, looking for other family members. So we would potentially could be going and testing his parents. It could have come from either of them, or it could have happened as a new change in him for the first time. So even though it happened in him for the first time, there is that 50-50 chance that it could then be passed on to children. The other common way that genes behave is in this autosomal recessive pattern. So here we still have these two copies of our genes, but the way that some genes work is that if you have a working copy and a copy with the change, the working copy sort of acts as a bit of a backup. So you actually don't have any health problems. It's not until two people who are both carriers of the same condition come together to have children that there is a chance that they could either both pass on their working copies and the child would be healthy. They could pass on the same combination, so a working copy and a non-working copy, and the children could be carriers like the parents, healthy. But there is this 1 in 4 or 25% chance that they could both pass on a copy that isn't working, and that's what can lead the child to have the condition. So I'll just finish off by talking about why it is important to know the genetic cause and what it can mean for people. So Lucy and Anthea have already gone into implications of treatment and management options for people. So I'm going to focus a little bit more about the implications for other family members, in particular donors, and also some family planning or reproductive options that can also become available once we know an underlying genetic cause. So if we know that a person's bone marrow is caused by a genetic reason, then we can offer testing to other family members. So in their situations, we might not be able to do something like fix the condition in them, but we could offer them things like screening to try and keep an eye on them. And any issues that do come up, we can catch them early, and that might mean more treatment options might become available. The other reason that we do talk to families about other family members being tested is the potential for them to become a donor for a future transplant, and you'll hear a bit more about that this morning. We do know that matched family donors do offer the best outcomes for patients, but we also need to check that if they carry that same genetic change that has caused their family member to develop a bone marrow failure, that we don't transplant someone who has the condition into someone that has the symptoms, because that can mean a very bad outcome for the person with the condition as well. So the genetic counselling that centres around that is, talking to people about wanting to know this information, because we're balancing it. On the one hand, there's the potential to help their family member and give them this incredible gift, but there is also implications for the person themselves if they were found to carry it, thinking about their own health and the health of their families as well. There sometimes are other implications as well that could come into play, such as some people are concerned about the impact of knowing this information on insurance or a job, something like that. So in Australia, there has been a lot of work done quite recently to try and limit the implications, mainly for life insurance, about what companies can and can't ask you about your genetic testing. And it also having a genetic test result doesn't impact on things like health insurance. But some people have some concerns about that, so we're really happy to discuss that before people have testing. And finally, I'll just finish on some family planning options. So for some people, not everyone, but some people do want to reduce their chance of passing on a condition to a future child. And we know if we know the genetic cause of a condition in someone, then there are options of either testing a pregnancy to see whether the developing baby would be affected, or using IVF technology to create embryos. And then we can test those embryos. This picture down here shows that. Test a few cells from those embryos to see whether or not they have inherited that genetic change. The other thing that we can do with IVF, and some people do look into this as well, is consider HLA matching. So choosing an embryo that could be a matched donor, for example, for a child, for their sibling that might require a transplant in the future. So this is certainly something we can have discussions about. It does involve quite a lot of discussions, and in Victoria also may require an ethics committee as well to provide approval for that to go forward. But that's something that we can certainly talk to people about. So thank you everyone there. I hope you found that information useful. I believe we are about to go into a bit of a mini question session, so using the Q&A function if you haven't already. And I've also left my contact details there just in case you wanted to get any more information about what we talked about already.
And thanks very much, Anna, for an excellent presentation. So we are entering into our Q&A session now with questions directed to our first three presenters. We know that there will be a number of overlapping questions, and there's been some excellent questions posted on the chat Q&A opportunity. Simon, are we bringing the other speakers on so we can see them?
Yes,
Great, so we have Lucy and then hopefully Anthea as well. And we'll keep an eye out for the hand raise icon as well for people if they want to ask questions live. Just before we get into that, it is 10 o'clock and we are running at about 10 or 15 minutes behind time, but I'm just going to keep going because I think it's been a very engaging presentation, and the whole point is for us to have the opportunity to talk. There is a break scheduled, but we won't know if you sneak off to make a cup of tea. So feel free to do that at any time. And so I think we'll just keep rolling. Just to let people know that the session, the whole session, all of the sessions, the whole symposium is being recorded. I'd let you know that for two reasons. One, so that there is an opportunity to access it after the fact, but we want people to stay on live if they can. And secondly, just if you do ask a question live, just make sure that if you don't want to be identified, don't use your name. But feel free to say whatever you wish, but it is being recorded. Okay, so we have our three panelists here. I might start from the Q&A forum here. So let me see if I can direct this to maybe just start with Lucy's presentation. So we have a question from Susan, who has asked us, specifically you, Lucy, that her husband's had a long diagnosis of aplastic anemia, some 20 years or so, and there wasn't any obvious underlying cause. Should he consider genetic testing now Susan doesn't particularly ask this, but I'll expand the question slightly, to utilize modern techniques for identifying maybe there was an underlying cause, or as Susan asks, the chances of a complication from the aplastic anemia such as leukemia developing.
Okay, so it's a good question, and the answer is very long, and I'll try to keep it short. Essentially, that AA term can describe that whole bunch of bone marrow failure syndromes. So idiopathic, that immune-mediated aplastic anemia, is one form. And then when the marrow is empty in, for example, Fanconi anemia, that has also been referred to in the past as aplastic anemia in the setting of inherited bone marrow failure. So the terminology can be really confusing. And I guess if your husband should have genetic testing or not really depends on if there's any diagnostic uncertainty about what has caused his bone marrow failure. And also on the severity of his blood counts. Okay, if his blood counts have been very stable for many years, and we're quite confident that his diagnosis is immune-mediated aplastic anemia, there may well be no point in going looking for an inherited cause. But at the same time, if there is any concern about what the underlying true diagnosis is, then we can go looking definitely for is there and what we call occult inherited cause there. Should he have that test that looks for developing leukemia, that one of them is looking at whether there's any acquired mutations. Like I said, the jury's still out as to whether we should go looking for acquired mutations, and in the setting of someone who's been stable for a very long time with stable blood counts, that's something that we wouldn't rush to do. But if there was any suggestion that things were worsening, then we would certainly look for acquired mutations that might indicate that something has changed in his bone marrow. So I hope that answers it, Susan, but if there's any more specifics that you need answered regarding his case, then you could send me an email and we can talk more about it.
Okay, thanks very much, Lucy, for that. There are a number of transplant questions which I'm going to hold over to the next session because we will be covering transplant in the next session. I might just ask Anna a question here, sort of a combined question from a couple of contributors, Kylie and somebody whose first name begins with J. So first of all, you mentioned in your talk, Anna, about pre-implantation testing and the possibility for in vitro fertilization to be utilized to avoid the ongoing inheritance of these conditions. Can you give some further advice regarding how available those fertility advice and services are? And possibly a little harder, but is there funding available for that for families who have these conditions?
Yeah, no, those are very good questions. So I guess in terms of the availability, so certainly if you're in a major capital city, so places like Melbourne, there are IVF providers that do offer this type of testing. So I guess it'll be a situation about being referred to have that genetic diagnosis firstly, and then going to an IVF provider, speaking to a fertility specialist there to learn about it. The funding, that does cause quite a lot of issues for people. It isn't cheap. It does range depending on where you go, but a lot of people do find themselves out of pocket, several $1,000s for something like that. So it isn't an option that's unfortunately available to anyone at the moment, and there isn't much in the way of Medicare funding, unfortunately. But yeah, we certainly do explore it as an option, but for some people it can be out of reach for those reasons.
Thanks, Anna. Clearly, really the genetic testing aspects of this and the counselling are hugely important for families and a cutting edge, as I mentioned before. And many of the questions and some of the solutions are still yet to be fully elucidated. Anthea, another question on the chat here regarding diagnosis. Are there any likely features at the time of a child's birth? And is there an opportunity to do blood testing at the time of birth to confirm a diagnosis for Fanconi anemia?
David, there may well be some features on examining a child, as I mentioned, so some skin changes or some changes in the hands or the limbs, etc., that may well give a hint to that diagnosis. It can be really hard in small babies, as you know, many of us will know from having small children ourselves. Everyone looks a bit different, and it's often a bit hard to tell at that stage. But it's something that clinicians may have an inkling about if there's something specific that we can see. So, you know, I think in reality for many families, particularly with something like Fanconi's, the diagnosis is often made later in childhood, where some of those things are a bit easier to sort of see when we look at a child. In terms of sort of testing at that stage, the testing for Fanconi's is reasonably complicated in terms of how that's done. Certainly, you know, it is available, and the testing's not limited by the age of the child, but it's a sort of complicated test, and given that many of these conditions are very rare, it's not something that we would generally screen everyone for. It would be something that we would be thinking about later on as the child is older, if it's clear that they're developing problems such as low blood counts consistent with bone marrow failure. I'm not sure if that's, so it is possible to make the diagnosis, but it would be an uncommon thing to do in a newborn without a really good reason in terms of, you know, taking blood off babies, and it's certainly not, it's a condition that is not common enough that we need to screen a whole population, but we need to obviously be aware of the symptoms and then screening children later on if we're finding that they have things that might suggest that that's the diagnosis.
And of course, a strong family history might point people in that direction.
Absolutely.
I'm going to take Chairman's prerogative and bring together a few questions because they're all so excellent, perhaps directed to a combination of Lucy and Anna. So there's a compound question here, partly about gene therapy. We're going to hear about that a bit later on, so I'll hold that part of the question over. But linked to that was one of the people who was asking a question from the audience has said that some patients with aplastic anemia have also, when on inquiry, been found to have inherited mutations. So just think about that part of the question for a second. And then linked to that, Rob has asked, he's had a history of aplastic anemia and recently completed some treatment. Is it worthwhile him considering a late presentation inherited disorder, not so much for his benefit, but for the benefit of his children and grandchildren? So I suppose to crystallize that question, what is the role for inherited mutations in the presentation of what appears to be aplastic anemia, and what is the value for family testing? And I might just start with Lucy for the first part and then Anna for the second part.
Sure. So to answer the question about aplastic anemia patient also having inherited mutations. So like I said in my presentation, when people are presenting with that empty marrow as they walk in the door, we need to think really broadly about, is this immune mediated, not genetic, or is this a genetic cause? And sometimes doctors think that this is immune mediated aplastic anemia. And in fact, we found on our recent research paper, we found 3 people who were being treated as having immune-mediated aplastic anemia. They actually had what we called occult, which is hidden, inherited cause. And that's why they weren't responding to their traditional immunosuppressive therapies. Okay, so that can happen in a very small handful of people that we think have an immune-mediated disease. So that is one really good reason where we go looking for a hidden genetic cause if people are not responding to immunosuppressive therapy. Clues that put us in the direction of patients being immune-mediated aplastic anemia are, firstly, if they respond to that immunosuppression, that gives us a real sense that, yes, this is immune-mediated, because if you've got dyskeratosis congenita, your blood counts won't respond to flattening out your immune system. And secondly, Anthea mentioned a PNH clone. Now, I didn't go into that in detail, but small clones of PNH are present in 50% of patients with aplastic immune-mediated aplastic anemia. Okay, so all newly presenting patients, and Rob, this probably refers to you as well, you would have been tested for PNH. If you have a PNH clone, that is a real tick in the direction of you having an immune-mediated aplastic anemia, and it would be very, very unlikely that you actually have something in the germline, an inherited thing that you would be at risk of transferring on to your children. But if you, on the other side, if you didn't have that clone and your doctors have given you as immunosuppression without any effect, and sometimes if you have other odd symptoms, such as something like a concurrent neurological problem or something else, that might point us in the direction of, or this could be one of these newer inherited diseases. And I'm thinking particularly of a new gene called SAMD9, and a gene that's only just been discovered because we found that in a 64-year-old man who wasn't responding to immunosuppressive therapy for aplastic anemia, and we found that in him it was actually because he had an inherited mutation. That's rare, but it can happen. So it depends on really that whole clinical picture. Okay.
Yeah, certainly, and I guess, you know, going on from that, if something was found and the implications for family members. So, you know, depending on what the inheritance is of a particular condition, that also influences whether or not we do offer testing for other family members. If it is one of those dominant type conditions, then there could be, you know, a 50-50 chance for your children. And in that stage, we would talk to them about if they were interested about the option of having themselves tested, because there are some things that we can do, as Lucy talked about in her talk, things like monitoring blood counts, even if you don't have symptoms now, maybe using some newer testing technologies to sort of look for those acquired mutations that might happen as well. But I guess it's also early days for that type of thing. And David mentioned before the Embrace trial. So that's something that Lucy will talk about a little bit later. But we're starting to see, you know, how could this play out in the future with more families?
That's great. Thank you. Thanks to all our panelists. There are quite a number of people who put on the Q&A. Thanks for your great presentations. Very informative, wonderful presentation. So thank you for all of that positive feedback to the panelists. I think we will just press on. Hopefully people will feel free to get up and make a cup of tea or find other ways of being more comfortable. And I think we'll press on with the next session. So thank you, and a big thumbs up to the first three speakers. Thanks very much. So moving on, just in order to make sure that we get through everything and give plenty of time for discussion, there are some questions that have been raised. We haven't forgotten about them. They will be a little bit more relevant for a later Q&A session, so we will get to them, I promise. So our next presenter is another pediatric hematologist called David Hughes, and he is someone who I'm very fortunate to have worked with over the years in my role at the Royal Children's Hospital. He's a relatively rare beast in the pediatric clinical sense, in that he is trained as a hematologist and bone marrow transplant physician at the Royal Children's Hospital. He's particularly through his own interest, and particularly because we have tapped him on the shoulder a number of times, he's really developed a strong interest in bone marrow failure syndromes in children. He is a participant in a number of the research protocols that you've heard about today and will hear about in due course through the rest of the session. And we're very grateful to have him here to talk about a particularly difficult area in bone marrow failure syndromes, the whys and wheres of bone marrow transplantation. So thanks very much for joining us, David.
Thanks, Professor Ritchie. I'll just share my screen if I can. 1 second, apologies. Am I working?
Yeah, that's great, Dave.
Great. Thank you, Professor. Thank you, MRV, for putting together this very useful and valuable day. I'm going to try and talk through really the basics of bone marrow transplantation in bone marrow failure syndromes. This is, you know, a fairly big and wide topic, so I've tried to keep it quite basic. I'm looking through the list of attendees down the screen here, and I can see that there's lots of people who have first-hand experience of transplant. They've lived through transplant with their own child. But I see a lot of names that are very familiar to me who we've had discussions about transplant, and transplant might be on the cards for their children, so hopefully this might be useful for them too. So I was going to start with a sort of summary of some of the basic principles of transplant, in that looking at what a bone marrow transplant actually is, who would we consider to be a good candidate for a transplant, what are our expected aims, and what are our the expected outcomes of the transplant. And then from a more practical sense, I might just talk through what the transplant journey looks like for a child coming through our service. So a bone marrow transplant, this might sound obvious, but the aim is to replace the hemopoietic stem cell, the bone marrow stem cell, with a healthy bone marrow stem cell from a donor. And as you know, the bone marrow stem cell really has two sort of key principles or key roles. First of all, it has the role of regenerating and proliferating itself to keep the bone marrow alive and functioning, but it also will proliferate or differentiate into all the different types of white blood cells that we've heard about before. So red blood cells, platelets, and all the various different types of white blood cells. So when we do a bone marrow transplant, we're really replacing the bone marrow stem cell, not one of the specific cell lines. So it's really quite a non-specific or quite a sort of broad-acting sort of process. For some conditions, that's really beneficial, because as we've heard, things like aplastic anemia, that affects all the different cell lines, and also the immune system can be affected. So therefore, replacing the whole bone marrow sort of environment actually is very beneficial in that setting. In other conditions where there's single blood lines affected, like in Diamond-Blackfan anemia, when the red cells are affected on their own, or in the various neutropenia syndromes, unfortunately we don't have a way of just replacing the red cells or the neutrophils. We can only replace the entire bone marrow environment. So it's a fairly big and all-encompassing process. The indications for transplant need to be really, we need to consider each patient very individually. A transplant isn't a one-size-fits-all sort of process. And we largely think about transplant, look at three different groups of patients. So the patients with acquired aplastic anemia will often benefit from a transplant because their entire bone marrow system really has failed. While we may try other therapies like Anthea talked about with immunosuppression, we know that probably the majority of children will need to proceed to transplant ultimately. And we use these sort of algorithms that we have here on the right-hand side, which help us with that decision-making process. And that largely depends on the age of the patient, the severity of their disease, and the availability of a good donor for transplant. The other group of patients are those with inherited bone marrow failure syndromes. And that's a much more difficult decision, because some of these patients will have conditions which can be controlled with other therapies. They may have some diseases which don't actually have much in the way of symptoms yet, and we have to try and really personalise our approach to transplant to time the intervention appropriately. So if a child, for example, is needing lots of blood transfusions because they're symptomatic from their low hemoglobin or their low platelets, then that might be an indication to think about transplant. Similarly, if they're having lots of admissions to hospital with fevers, then again we might think about intervening. Another group, fortunately a very rare group in children, is the children who progress to have leukemia or sort of a pre-leukemic disorder called myelodysplastic syndrome, and those are the children that we really need to push on with transplant fairly urgently. It's very important, especially in the inherited bone marrow failure syndromes, to remember that a bone marrow transplant only fixes really part of the problem. It only fixes it sounds obvious, but the blood and the bone marrow component of their disorder. So in conditions like aplastic anemia or in congenital neutropenias, where the problem is confined to the bone marrow, then essentially we can say that the bone marrow will cure that disorder. But in the other conditions, like we've heard about with Fanconi anemia, for example, or disc keratosis, where there's multiple organ systems in the body involved, the bone marrow transplant won't cure that. It doesn't fix the liver or lung problems, or it doesn't fix the pancreatic insufficiency of Shockley-Diamond syndrome. It simply improves or give some symptomatic improvement to the hematological component of their disease. So with that, when we're thinking about a transplant in a child, we have to be really sure that we understand or really consider what our aims are of the transplant. And again, this may sound very obvious, but we need to just balance up what we're really doing it for. Are we expecting to increase the life expectancy of the child? Are we looking to improve the quality of life, like make them feel better, that they'll need less transfusions, less trips to hospital, they'll get to school more, their education will improve? And in some conditions, where there's a high risk of transformation to leukemia, then sometimes we might aim to reduce that risk. Our outcomes from a transplant, first of all, are excellent, but there are a few things that it depends on. It depends on some factors with the patient, some factors with the donor, and then some factors that we have sort of really no control over externally. So we know that the younger the patient, the better they tend to do. It depends on the disease. Some diseases respond very well to transplant, some diseases are much harder to treat with transplant. It depends on the performance status of the patient, so how their current quality of life is. Things like infection, if they've had lots of severe infections, then that can make the transplant a much harder process. Similarly, the donor is very important, so we want a donor who's a good match. We want a donor who's young, preferably. We want a donor who necessarily doesn't have a big infection history. We want to potentially use a donor who's sex matched, so the same sex. And then there's other factors that control or affect the outcome of the transplant, like the medications that we use during the process. All the things together give us a predicted outcome. As you can see on this little graph here, we can see that, for example, in aplastic anemia, there's about a 10% survival benefit if you are under the age of 30 at the time of transplant versus over the age of 30 at the time of transplant. Overall, it's very important to remember that transplant has very good outcomes in children. On the right hand side here, we can see this is data from Europe. Unfortunately, my reference seems to have fallen off my slide, but this is European data, which shows that children with aplastic anemia have a sort of overall survival at 5 years, and then out to 10 and 15 and beyond. They have an overall survival of 92%, which is excellent. If we look at children with the inherited bone marrow failure syndromes, again, the outcomes at 5 years are exceptionally good at about 96%. But it's important to remember that not every patient with inherited bone marrow failure syndrome is the same, and there's some groups within that cohort who don't necessarily do quite so well with transplant. So we have to be very careful about our decision making, because we know that children, for example, with Fanconi anemia or with disc keratosis congenita tend to have a much harder time with transplant, and the overall survival is not so good. So then briefly to finish, I was going to just talk more practically about what a transplant journey actually looks like for a patient coming into this hospital and to most hospitals. It's a very long and protracted phase. It's a journey which probably lasts for about 2 years in total, so it needs a lot of consideration before we commit to that journey. And I'll just go through each step briefly in turn. So the first step, which takes about 2 to 3 months typically, is to really start doing some good preparation. So the first thing is to find a good donor. About 20% of us will have a matched sibling donor who's really the optimal donor for a transplant. For the other 80% of people who don't have a matched sibling donor, we'll look to the international registries to see if we can find a good match. At the moment, there's about 37 million people signed up to the international bone marrow donor registries. So the chance of finding a donor on those registries is high, but there's still about 10% of people who we don't find a match for on those registries. And for those people, we can still find, there's still options. We'll often use a half a match or a haploidentical transplant, and in paediatrics we'll often look to a mother or a father, or sometimes a sibling for that. In those few months of preparation, we work really hard to try to reduce the risk of complications during transplant. So we will screen the patient very hard. They'll have CT scans and looking for hidden infections so we can treat the infection if they have some. We will look hard at their liver function, at their kidney function, so that we can try to bring the patient into the peak physical shape before they start a transplant. They need central venous access, so we insert a Hickman line, which looks like this, and that allows us to administer the chemotherapy straight into one of the big veins. and it can do lots of blood tests from that too. A very important thing that we concentrate on in paediatrics especially is to try to see what we can do to preserve the child's fertility. We know that a lot of the medications that we use during transplant can result in subfertility. So we can do procedures, whether that's semen or egg storage, or testicular or ovarian biopsies in children, to see if we can try and preserve their fertility for later in life. And one of the really key things, and we're very lucky in this hospital that we have a psycho-oncology service who are very committed to transplant. But one of the really key things is that this is a massive burden for a family and for a young person to go through. So we try to use that 3-month preparation time to really get them really emotionally and psychologically prepared for the impact of transplant on their family. About 8 to 10 days before the actual transplant day, we admit the child to hospital, and that's for a combination of fairly intensive chemotherapy, immunosuppressive therapy, and we start a lot of medications to try and reduce the chance of infection, because we know that their immune system now is obviously going to be very suppressed. Then it comes to transplant day, and transplant day is for 95% of people a bit of an anticlimax, actually, because it seems just like a blood transfusion. Now, that's not, there are rare circumstances, and I know Jess might talk about this later, but there's rare circumstances where people can have reactions to the stem cell product, and that can be quite traumatic. But for most people, the stem cell infusion takes about 30 minutes and it's very uneventful. And then we have to sit and wait for the bone marrow to start working. And in that time, if we're honest, people can be quite sick in that period of time. So people can need a lot of blood transfusions, they can have infection and fever, and there's specific sort of transplant complications that can happen, like graft versus host disease. During this time, they will need a lot of nutritional support because their gastrointestinal tract will be quite sick. But as we move towards the end of that 100-day period, life gets back to more normal. So the patient will be well and truly discharged from hospital, they can get their Hickman removed, our children will often be going back to school about day 100. But that's not the end of it. Then I suppose we have this really protracted period which can last for about 2 years, where we keep the patients under really close monitoring. So they'll have trips to hospital maybe once a week, once a month. And we're looking for other complications of transplant, like chronic graft versus host disease. We're looking to monitor their lungs and their heart and their growth and their puberty and development after the chemotherapy we've given them. We have to revaccinate them because we've destroyed their immune system, and all the vaccination or the memory that their immune system got from vaccinations previously is now wiped out. And it takes about 2 years typically for their immune system to be really recalibrated or really back to full strength. So it's a very long and protracted journey for transplant, so it's a really careful, we have to really make sure we've really sort of given it careful consideration before we start the journey. So I'll just finish and I'll just say that where we've seen the outcomes for bone marrow transplant is incredibly good, and the sort of incredibly effective therapy. There is risk, and we need to really spend a lot of time weighing up that risk and benefits. We, as physicians and with the family, we need to spend a lot of time really planning the transplant very meticulously, because that is how we improve the outcomes. And we never underestimate what a big commitment that is for the whole family, and we can see that with our families. It's a massive impact. There's, you know, the kid is out of school for a period of time, the mums or dads can't go to work for a period of time. So it's a really big commitment, and we would encourage you to have lots of discussion with your physician prior to make sure it is really the right decision for you. And on that, I will hand over to Professor Ritchie.
Thanks very much, David, and a huge topic to cover in a short time, and there's fantastic questions coming on through the Q&A facility, and we will get to those, I promise. I do want to just move on. We are running about 15 minutes behind, but I really want to leave time for questions and panel discussion. A really very important person to speak next in the session is Mei-Ling Ye. So Mei-Ling is the Maddie Rewalt Vision's telehealth nurse. Her position has been made available through a grant, and MRV really felt that having someone such as Mei-Ling in this position would provide an opportunity for information sharing and for good advice as people move through these diagnoses and their treatments and have questions. So Mei Ling does have a long and distinguished career as a pediatric oncology nurse, and she really does want to utilize her experiences in patient and family-centered care, specifically now focused on advice and support to families with bone marrow failure syndromes. I would like to thank her for giving the nursing perspective of bone marrow failure syndromes to us next, and of course she'll be available as one of the panelists to answer questions at the end of this session. So thanks, Mei Ling.
Thank you, David. Thank you, David, for the introduction. Can you hear me properly? Yes?
Yes, all great.
Cool, thank you. Yeah, I'm really delighted to have been appointed the Maddie's Vision telehealth nurse in March this year. The position complements my clinical nurse specialist position at the Royal Children's Hospital in a really good positive way. I'm going to present to you all today some of the insights I have gained through my career, as well as explain how I can assist you all at the Maddie's Vision telehealth nurse. Oh, sorry. Wait. Oh, yeah, sorry. So, as Anthea, Lucy, Anna, and David explained earlier on this morning, because of the complexities of diagnosis process and the treatment protocols, patients and families are encountering significant challenges throughout their journey when dealing with bone marrow failure syndromes. Like the patient said, chemotherapy and radiotherapy destroyed my inner systems so badly that I was bombed from inside, and it made me so sick that I even can't fight for it. Some others have said to me that me and my family's life have been changed on the minute of the diagnosis. I feel like I can't even dare to plan for my future. Like cancer or other chronic conditions, most of patients affected by bone marrow failure syndromes experience various levels of emotional distresses, as you all can imagine. According to research, receiving a diagnosis of cancer or other chronic conditions and undergoing its treatment together comprise of an extremely stressful situation that can render individuals vulnerable to long-lasting negative psychological outcomes, including emotional distress, depression, anxiety, guilt, sleeping problems, fatigue, and impaired quality of life. Especially since bone marrow failure syndrome is such a rare condition and limited information is available to research on, sometimes it might add on more unexpected complications whilst making decisions for self, spouse, or kids or other family members. However, the beauty of life is that we always find a way out of our struggling situations, like the transformations from a caterpillar to a butterfly. It has been well recorded that many chronic illness patients and families manifest remarkable resilience. Studies have also shown that personal and post-traumatic growth are often developed from overcoming illness and its treatment. Mental and emotional well-being are potentially linked to the better coping with disease-related demands. However, unfortunately, not everyone reacts to hardship in the same way, with some more resilience than others, and some might need more assistance than others. So lots of research show the first few months after diagnosis with life-threatening illness is a critical period. During that period of time, they are confronted with numbers of physical, psychological, social, spiritual, and existential changes imposed by the disease. This period is characterized by existential distress, worry about the death, safety, fear about dependencies, lost autonomies, and death. This illness triggered existential concerns often confuse our general sense that life has its own order and purpose as well. So this forced many patients to search for new meanings in life as they struggle to make sense of their illnesses. And this is where Maddie's Vision Telehealth Consultation Service can step in to assess. Based on my years of working at the clinical setting, I utilize my knowledge and skill to provide strategic service to anyone who is affected by bone marrow failure syndromes, both physically and emotionally. I can deliver information, resources, materials about conditions, symptoms, test, treatment, and symptom management. I understand that the needs and struggles encountered day-to-day living with bone marrow failure syndromes. And I hope to improve the quality of life for my patients and their families by providing educational resources and emotional support. With a group support from doctors, scientists, social workers, clinical nurses, and many others, I can provide you with most accurate information available through the phone calls, emails, or any other methods that suits you better, the best also. I have been often asked what is the best way to deal with their challenging situations. I think the first thing I would like to say would be believe in yourself and be nice to yourself. Aware of what your body's trying to tell you, and also believe what you can do and maintain your positivities. You are your own best friend and know yourself better. The best example I always share is the energy and the vote theory, which is shared by one of my lovely colleagues of mine. When patients are struggling with their situations, and I always tell them, think about yours, and also with, for example, severe fatigue. And I say to them, think about yourself as 50% or fully you are now fully charged batteries, and you are always there 50% of capacity. So when you are aware there is no much energy going, you need to think about how to save your energy in the best way throughout the day and plan your activities better accordingly. Secondly, it is important to build a strong healthcare team. We live in a world where it can sometimes be difficult to gather and trust the information that you come across, which means that not everything available online is true or applicable to you. And we need to be more vigilant with what we read. So it's important to build a trust healthcare team who will not only provide medical care advice you need, but also understand your concerns and challenges. Your healthcare team will keep you well informed about your disease and the treatment options. Once you have developed strong input with your healthcare team, and it can help educate your families, friends as well. And this knowledge will contribute to make more informed medical decisions for yourself. Finally, build a supportive team and fully utilize it to help you to go through your challenging times. Peer support is one of the greatest resources. Just remember to be clear and direct about your needs and expectations. For example, you don't need 20 or 50 boxes of pasta in your fridge. right? So if you know this friend is very good at cooking, and let her cook for you when you are in the hospital or when you need it. And another example, if your parents are very good with your other kids, ask them to your help, ask them for help and schedule their babysit regularly. Coping strategies vary from person to person, and identify what is the best way for you and your family, as no one can decide this for you. Discuss with your partner or family about the role and expectations, and how are you going through this journey together. Work as a team. I always like to talk to the parents in the hospital. Have some time for you both. Go out, have a coffee, have a cuddle together, and kiss each other. Just give yourself some time together, and then to re-immerse your emotions and talking about what's going on. Yeah, and also like a shift rotation in the hospital, or you guys can talk about the home time with the other kids, and even the exercise schedule is very important. Although there's no such thing as a routine in the hospital when you are in a hospital environment. However, if you are preparing with all the resources you have all together, and it might make it easier for you to deal with unwanted incidents when it occurred. Yeah. Sorry. Yeah. Next. Sorry. So about the caregivers, do you know there are very types of caregivers? It might be important for you to identify your role. And we understand that most of people often think about they don't need help, and it is something that comes to us naturally as well. However, it is very good to talk to someone about changes, challenges, or even minor concerns to know what is okay, just to ask for help. As a caregiver, this is not always a person providing hands-on help. These primary cares can be backed up by secondary caregivers who may provide occasionally help on the weekends or other times when you need it. And their support can be in the form of emotional support for the primary care as well. So it can, and there's another type of the caregivers, is a long distance caregivers. They are tied to that person by bond of affection, and they're affected by the needs and illness of their loved ones, and offer support in other ways without being on site for assistance. So in conclusion, as I mentioned previously, good direction to your support resources, and when people are offered support, identify their availabilities and limitations, and to be clear about your expectations. And because the clear expectation is all what you need, and this is, as you would know, and like David mentioned before, it can be years journey. So this is the long-term process, and if we can, we plan it well as possible. Finally, I would like to emphasize on tracking your own health information. Keeping track on your medical record and health information can be quite a task, but being able to put your hands-on paperwork you need within a minute can be a little bit challenging, but it will be so helpful as you prepare for a medical appointment and advocate for your health, and also this healthcare information will help you to know your disease is in progressing and how well your treatment is working. So in here, I would like to mention about Maddie's Vision Patient Treatment and Care Plan report. It's a great example. So what we are doing is not only saving your time of repeating the same story to different healthcare professionals when you visit them, but also checking your information properly for easier appraisal. Finally, my recommendation is to make the list of the questions before you visit your doctor as well. Any type of questions, simple questions even, you think this one will help you to get the best out of your doctor visit. As you guys might, as everyone might be aware, Maddie's Vision has been working closely with our airlines to provide information, resources, and services to our patients and families. And this is our resources. And finally, I would like to special thanks to the lovely family who are close to working with us, and thank you for your time and the contribution, and Maddie's Vision team for the toward to this presentation. And also, my position is part of a national patient pathway pilot program, which is an initiative funded by the Australian Department of Health and coordinated by the Centre of Community-Driven Research. And I'm very appreciative of CCDR's support. Thank you, everyone, for your time. Get back to you, David.
Thank you, Mei-Ling, for an excellent presentation. We are still running behind time, and I do want to leave time for questions at the end. I'm going to move on without any further ado to Tommy DeSallo presentation, now getting into probably the most important part of the entire day, which is the reflections and the experience sharing by patients and family members of patients. Some of you might know Tommy as a stand-up comedian, actor, illustrator, and writer, and he's extremely well-traveled, has a number of very well-subscribed podcasts, and has been an international performer on the stand-up comedy circuit for many years. He did undergo bone marrow transplantation as a very young boy for aplastic anemia, and he has a particular perspective in that respect. And I welcome him with great warmth and thank him for his time and sharing his observations of his own personal experience and the experience of those around him. So thank you, Tommy, for joining us.
Hi, thank you for having me, David, and everyone at Maddie Rewalt Vision. Yeah, it's a real honor and privilege to be asked to speak today in what will no doubt be the most ill-prepared and under-researched presentation you're going to see today. Unlike everyone else who's spoken today, I don't have any slides in my presentation, if you can call it that. So yeah, that's just to let you people watching know that yeah, there's no visual component to this. So if you feel like leaving the room and getting a cup of tea, or you know, just doing whatever you need to do in another part of the house, you're not going to miss anything by not being directly in front of the computer for the next few minutes. So yeah, as David said, I am a comedian by trade, or at least I used to be before the live performing arts scene was completely decimated by the coronavirus. I have done stand-up comedy performances about the aplastic anemia that I went through as a young child. I was 10 years old when I was diagnosed, and I then spent about 2 years in and out of the Royal Children's Hospital pretty frequently. And then at age 12, I had a bone marrow transplant, which was successful, obviously. And Yeah, this is a completely new thing for me. I have joked in the past in my stand-up and other avenues about my experience, my patient experience, because to me it's something that you know, by making fun of something, you kind of you know, you remove the power that it can have over you. And so but speaking in this kind of manner about it is a very new thing for me. So I apologize if this is not very good. Yeah, it's an interesting thing to be asked to give a patient perspective on something like this that happened when I was 10 years old, because to be completely honest with you, I don't have a great deal of perspective to really offer because I was quite young. Like I said, I was 10 years old. I don't want to reveal my age by saying how long ago that was, but it was roughly 13 years ago. And there's not a lot of it that I remember in great detail because I was quite young. It's quite a while ago. I think it would be fair to say that it's quite common to be kept in the dark about what is going on when you're that age by the people around you. I think that is a completely fair enough position. And also, I was pretty heavily medicated in one form or another for most of those 2 years. So I'm in this strange position where I have done a one-man stand-up show about my experience, and I suppose if this was happening in a live setting, I would probably do a part of that, I guess, but doing stand-up material over Zoom seems somewhat mortifying to me. So what I thought I would do instead is I'm in this strange position where my dad, I found out quite some time ago, has been slowly working on a memoir in his spare time of his life experiences. And so I have a chapter of his memoir that he has written about my illness and the time that he and my family spent in the Royal Children's Hospital. And so I thought I would just read to you guys a little bit of that, and I'll have some interjections. And so yeah, this is in place of me being able to give my own fully realized patient experience to you. So yeah, here we go. This is a sample of a chapter of my father's memoir. Here we go. It has been said that we remember the exact circumstances, how and when we received momentous news. For me, one of these instances occurred at 7:30 on Wednesday the 15th, 1995. We had just finished dinner when the doorbell rang. It was our doctor who said she was calling in because she had lost our telephone number. Of course, what she really meant was that she needed to see us in person urgently. A couple of days before, she had seen our son Tom, who had been looking very pale and was complaining about being tired. She had ordered a blood test which showed a dangerously low hemoglobin level, very few red blood cells. She said that he should go to the Royal Children's Hospital without delay. It was evident from her demeanour that his condition was of great concern to her. Early the next morning, we were admitted to the Haematology and Oncology ward of Melbourne's Royal Children's Hospital. Tom was given a blood transfusion immediately while we were interrogated by what seemed to be an endless line of people, all asking us the same questions. Later that day, we were shown into a small room and introduced to our specialist, haematologist Dr. Peter Downey. He described what he believed the test would confirm was Tom's illness. Tom had a severe case that needed immediate attention. It was clear from what he was saying that recovery could not be assured. He would need regular blood transfusions and intravenous therapy. My wife and I were then left alone in the little room, quite numbed by the news, our minds racing. How could this happen to such a healthy little boy? We returned to his bedside to find him cheerfully reading, of course oblivious to the unfolding drama. Now that he was out of immediate danger, we were told to take him home for the weekend and return on Monday morning for his first operation. It was not a pleasant weekend. Tom seemed well with replenished red blood cells. We knew this was temporary and that we had to prepare ourselves for the long haul. I advised my office that I had no idea when I could be expected next. The following Tuesday, he started an unsuccessful intravenous course in the hope that it may revive the bone marrow. The treatment made him very sick with a fever, rashes, vomiting, aches and pains, you name it. We were then told that his only hope would be a bone marrow transplant. We had no idea what this involved and how difficult it was going to be. After the ward was bedded down for the night, we were told to go home. We did not settle, so when the telephone rang in the small hours to say that Tom was distressed and wanted us, it was no surprise. We vowed from that moment on that we would never leave him, at least while he was awake. Another bone marrow biopsy was done, this time under local anaesthetic in the treatment room. It is a very painful process. A hollow needle is used to collect a sample from the hip bone. The test confirmed Dr. Downey's original suspicion. Tom had severe aplastic anemia, a condition wherein the bone marrow simply stops making blood. The causes are not fully understood and it is extremely rare. Tom's reaction to each blood transfusion varied. Often he suffered the most terrible itching deep in the soles of his feet as soon as he lay down to go to sleep. There was no relief and often he would be screaming in pain. The only thing that helped was to go for a drive. Tom and I got to know Melbourne very well between 2 and 5 a.m. We would choose a distant suburb and then go there to see if their McDonald's was 24 hours, not because we wanted to buy anything, but just to give our trip some purpose. Just before Christmas, he was started on a daily injection of GII/CSF. The doctor made the foolish mistake of saying that it would not hurt. The fact is that it is painful with a lingering sting. Initially, an hour or so after the injection, he suffered agonizing stomach cramps. He was kept in hospital for more than a week until some way of avoiding this discomfort was devised. There is a belief that Christmas in the children's hospital is some sort of fun. It's not. Only very sick children are kept there and there are the minimum number of staff. Carol singers, bands and Father Christmas only heightened the loneliness and desperation of our Christmas in '95. I just want to interject quickly and say that Christmas of 1995 was the year that I got given a Super Nintendo as a present. So from my perspective, not all that bad. On the odd occasions when we were allowed to be at home, it was arranged for someone from the Royal District Nursing Service to visit each morning. Every couple of weeks, quite suddenly and invariably at night, Tom's temperature would rise, indicating that he had another infection, that we had to go to the children's hospital immediately. We were so used to this that we had suitcases always packed and sitting at the front door. We were lucky also as we had no other children to consider and at that stage, no pets. Sometimes there was no bed available in our regular part of the hospital and we would end up in strange surroundings and with strange nurses. In these circumstances, we could not possibly leave him even when he was asleep, so we would lie on the floor and try and get some rest. A vinyl floor is a hard mattress. We were always told that the intravenous antibiotic treatment in hospital would take a few days. It usually took 10. The days dragged into weeks and then months. I think a lot of our friends and families became bored with the lack of progress and we felt as if we had been forgotten about. Perhaps the truth is that these people did not know how to connect with us. In any case, it was a very lonely time, whether we were at home or in the hospital. It was clear by Easter that Tom was slipping. He was becoming more susceptible to infections and the transfusions were not lasting as long. We were told that a bone marrow transplant was now vital. Jane and I were both tissue typed, but were not close enough matches. They tested members of both families, but still not a satisfactory match. The search went on in earnest. Friends and acquaintances through school and work all volunteered. We were pleased to take credit for at least 100 new names on the international register. The sad thing is that there are probably more tissue types possible than there are people in the world. Many people die waiting for a match to be found. This time was torture for us all. Tom was so sick. We were confronted with the very real possibility that a match would never be found. On one occasion, we visited Peter Downey at Cabrini. Jane, my wife, was distressed and excused herself from the room. A little while later, Peter followed. We found Jane sitting on a bench in the car park with Peter's arm around her, comforting her. It was an act of extraordinary kindness, unusual and probably unwise in the medical profession, but that is the sort of person that Peter is. Finally, we were told rather casually that a good match had been found in the United States and that arrangements were in hand. Transplants are performed in strictly isolated conditions in one of 2 rooms. We had to wait our turn, but there were also details to be attended to on the other side of the world. Early in our involvement with the ward, we discovered that we desperately needed an alcoholic drink with the 6 o'clock news. One day we were enjoying our drink when a hawk-like nurse came and said, "We're not drinking in the ward, are we?" We looked as innocent as can be, not challenging the statement. The next day I got some small bottles of apple juice and I used these to smuggle our alcoholic drinks into Tom's bedside, and we would leave the bottle prominently displayed while we enjoyed our evening tipple. Life plodded on until the 6th of April 1996, when we were admitted to Peter Callum Cancer Institute for 6 sessions of radiotherapy over 3 days. This process would deactivate any remaining bone marrow. The cancer hospital was much quieter. All the people we saw on our level looked awfully sick. It was a distressing environment, the only highlight for Tom being the transfer from there back to the Royal Children's Hospital in an ambulance. He was annoyed that they would not turn the siren on for him. He then started on a course of chemotherapy. It was now Tom's turn to adopt the Andre Agassi look. Over 2 days, all his hair completely fell out, leaving him with a dusting of baby-type white hair. This did not worry him one bit. Got to say, I wouldn't mind a bit of dusty baby white type hair right now at age 34. But anyway, at the arranged time on the 15th of August, the bone marrow arrived with a courier at Melbourne Airport. It was checked at pathology and prepared to be transferred to Tom. The process started at about 1 p.m. and took about 4 hours. The new marrow looked just like a half-litre bag of blood and is introduced into the bloodstream. By some miracle, it finds its way into the bones. We were told not to expect any response for about 2 weeks. It was an anxious wait. During this time, he had no defense. The chemotherapy had upset his digestion to such an extent that he was incapable of eating. A continuous drip of morphine helped ease the pain. This is how he spent his 10th birthday. On the 13th of September 1996, the specialist in charge of the transplant process announced that Tom was to go home. The Olympic Games were in full swing in Atlanta. The ward was abuzz because Kieran Perkins and Daniel Kowalski were competing in a major swimming event. We slowed our packing up to see the magnificent win. Somehow it was an omen for us for the future. As we pushed Tom out in his wheelchair, we felt even bigger winners than Kieran on that day. Back home, life was still far from normal. Tom had to take 33 tablets every day, some before food, some after, some early, some later. It was a major process arranging them. One tablet with 23 possible side effects listed on the pack often made him vomit in the morning. How the three of us filled in those months, I do not know, but we always seemed to be busy, our little team. About this time, my mother's health deteriorated dramatically. Her mild dementia had been suddenly accelerated by a general anesthetic necessary when she broke her hip. It was very distressing, but mercifully, the sudden onset saved her the conscious indignity of her predicament. We visited Peter Downey on Friday, the 23rd of August. He explained to Tom and the blood test results and then announced that he believed that Tom was cured. We left the hospital knowing that we would still have to visit often, but it seemed that a huge grey cloud had lifted. I visited Mum in the afternoon and gave her a hug and told her what the doctor had said. Then I sat with her, holding her hand as she stared vacantly at me. She died peacefully that afternoon. I believe she waited for the good news. In a social situation, a psychologist, as part of some research he was doing, asked what techniques we used to get through. It was simple. We remained positive. We never had a negative thought, and we never spoke to one another of anything but success. And so that's the very abrupt end of my dad's chapter about our family's time in the Royal Children's Hospital. And my dad was quite keen for me to relay to people that since then, since making a full recovery, I've been more or less incredibly healthy. I ran last year in the City to Surf up in Sydney, which, given my appalling diet during stage 4 of lockdown, I don't think is a feat that I could replicate 1 year on at this stage in time. But yeah, that's it. That's my patient perspective. I'm sorry that I don't personally have more to offer, but my only great memories of that time in Dad's story, parallel to Dad's story, are that there's a McDonald's at the hospital, which I remember being very excited by when we first went for that initial visit. So I didn't think that a thorough examination of what was going on with the Happy Meal in the year of 1995 would have been particularly interesting or of any great use to anyone at this forum. But yeah, that's me done. And yeah, thank you for having me speak. And I look forward to watching the rest of today's forum.
Well, thanks very much for that, Tom. And just to let everyone know that that the author of that incredibly moving and insightful chapter is one of our call-in participants today. So thank you to him for allowing for us all to hear that. Tommy, we better move on, but I do want, of course, ask you to rejoin us, so don't run away. You have got time, 30 seconds to make a cup of tea if you need to. But on behalf of everyone, all 150 so people who are on the call today, big thumbs up and thanks very much. Incredibly moving and really important contribution to today's session, and we'll hear more from you in a little while. So let's now just move on to the last presenter in this session, and I do want to give people plenty of time for Q&A, and we've had really a great number of questions put on the Q&A, and keep them coming because we will get to them. Our next presenter is really incredibly accomplished, as well as Tommy has been and still is. Jessica Lake is our next presenter. Dr. Jessica Lake, a really accomplished writer and academic in law at Swinburne University, published nationally and internationally in a range of different areas, has a very important and particular perspective as the mother of a young boy, her son Larry, who was diagnosed with aplastic anemia. Jessica, of course, is always willing to give her time for the benefit of others, and as part of that is member of the Parent Advisory Group at the Children's Cancer Centre at the Royal Children's Hospital. And she's really writing a very powerful piece, which I don't think has come out yet, but is due to come out, called Hemopoiesis, Blood Poetry. And I really would like to welcome Jessica for giving her time today to share her perspective. So if we can get Jessica up on the webinar, that would be great.
Thanks so much, David. I'll just share my screen. Okay, I hope everybody can see that. Okay, hard to follow in the footsteps of a stand-up comedian, but I'll give it a go. Okay. On the left is a picture of our son Larry, taken in May 2018. 3 years old, dark mop of straight hair, rosy cheeks, red lips, throwing himself through life as a joyous, cheeky, musical, robust toddler. And on the right is a picture of our son Larry, taken just a few weeks ago. 5 years old, exuberant, curly golden hair, full of energy, full of jokes, full of stories, and mostly full of health. But this morning I'm going to talk briefly about what happened to him and to us during the years in between these two photos. In mid-July 2018, I noticed a small patch of red dots like freckles on Larry's neck. The patch was no bigger than a 10-cent coin, and we weren't too concerned. Larry seemed well. He'd always been a healthy little boy, the bigger and stronger of our identical twin boys. Always rumbling and playing with his brother Henry and his big sister Matilda, who was then 6 years old. And so the dots didn't worry me. I thought they'd probably just go away on their own, probably just caused by a passing virus or a minor injury. But a week later, the dots hadn't gone away, and I noticed in the bath one night some very red, purpley and angry looking bruises on his legs. I decided to take him to our GP for a checkup, and she sent us to Monash Children's Hospital Emergency Department for a blood test. We attended Monash Kids on the morning of the 24th of July 2018. 2 hours after Larry had been entertained and distracted into having a cannula inserted and blood taken, an ED doctor approached me and told me, while I sat on my own on a plastic chair with my squirming bored son on my lap, that a doctor from the paediatric hematology and oncology department was coming down to speak to me. How to describe that moment? It's a bit of a blur, to be honest. Fear, terror. I felt we were suddenly slipping off the edge of our own lives. I felt that our lives, as we knew them, were beginning to dissolve. That night, Larry stayed in the Monash Children's Cancer Centre for further tests and scans. And for the next 3 weeks, we all held our breath, our family, our friends, and the doctors, and watched his blood results. Hemoglobin in the 90s, neutrophils just below 1, platelets slowly dropping, 24, 24, 22, 20, 18. He was soon scheduled for his first bone marrow aspirate, and the next day we were summoned, No, it wasn't leukemia, they said. Aplastic anemia. I'd never even heard of this disease. By mid-August 2018, we'd moved to the Royal Children's Hospital. We had an appointment with Dr. Chris Barnes, and from him we were referred to Dr. Dave Hughes. We were checked into the ward immediately, and Larry was given another cannula and hooked up to his first red blood and platelet transfusions. Despite our assurances, our attempts to comfort, and our rudimentary explanations, our little 3-year-old boy was confused. It was a confronting and upsetting afternoon. From August to October 2018, we were told many things. We were told our son's marrow was dying. We were told to watch for any signs of bleeding. We were told he could no longer attend childcare. We were told to schedule weekly appointments at day oncology. We were told to rush immediately to emergency if he ran a temperature. We were told he would require a second bone marrow aspirate. We were told he would need numerous transfusions. We were told he required lots of different medications. We were told he would need a bone marrow transplant, likely involving 6 to 8 weeks of isolation. We were told all genetic tests had come back negative, and yet there could still be an unknown genetic component hidden in his DNA. We were told his twin brother might come down with the same condition and could not be his donor. We were told our daughter was not a compatible match and could not be his donor. We were told he would need a Hickman line inserted into his chest. We were told there were no match donors on the Australian Bone Marrow Registry. We were told his mixed heritage, Chinese and European, made locating a match less likely. We were told there were 3 possible donors on the International Bone Marrow Registry, 3 out of approximately 40 million. We were told his transplant would begin in October or November 2018. But then we were told that none of the donors were answering their phones. Then we were told that his transplant would not go ahead. Then we were told that he would start immunosuppressive therapy instead. And we were told that due to his very young age, it was unlikely to be successful. Day after day during the diagnostic period, news punched us in the face and we were left spinning. These illustrations from Alice in Wonderland, which I read to the kids, best represent my sentiments at the time. I felt as though we were in free fall, and I felt that we were trapped. What is happening, and how on earth do we get out of here? Larry underwent horse ATG in October 2018. After 2 weeks on Kookaburra, he was discharged. However, 3 days later, he spiked a fever and was readmitted for 5 days. 4 days later, he spiked a fever and was readmitted for 9 days. 3 days later, he spiked a fever and was readmitted for 12 days. Larry was finally discharged in late November 2018. In December, his blood results began improving, particularly his neutrophils. They continued to improve throughout the heat of January, but in February 2019, they deteriorated again. He underwent a second round of ATG, this time rabbit, in April 2019, in the hope the effects would be more pronounced. They weren't. By now, Larry had lost a significant amount of weight. He wasn't eating much. He wasn't sleeping well. He was less engaged. He was anxious. He did not seem himself. It was very hard to witness as his mother. But by now, thankfully, a compatible overseas donor had been located. And so, with hope and trepidation, we prepared for transplant. On the 22nd of August last year, all 5 of us arrived at Kookaburra Ward, laden with belongings. While my husband minded the kids, I decorated Larry's room. creating the most familiar, welcoming and warm space I possibly could. Our kids played together in the corridors, ate icy poles together from the ward kitchen, hugged, then said their goodbyes. And Larry and I walked into the BMT unit. We walked in slowly. I was acutely aware that as soon as the heavy glass door closed behind us, Larry would be trapped, unable to leave. For the next 6 weeks, my husband and I took shifts. One of us was always in room 204 with Larry, the other one on the home front looking after Matilda and Henry. We had many very difficult days, physically, emotionally, logistically. But all in all, the 6 weeks of transplant actually went fairly smoothly. Larry engrafted by day 11 or so. By day 20, he was making his own platelets for the first time in over a year. By day 30, he was making enough hemoglobin to be pronounced transfusion independent. We were overjoyed to go home, for the family to reunite again. But 2 days later, he contracted run-of-the-mill gastro from his brother Henry. Henry, with a normal immune system, recovered in 3 days. But Larry spent 3 to 4 weeks vomiting and losing yet more weight. We were in and out of hospital almost every day again, on the phone to day oncology, fast track or the ward at all hours, teetering on the edge of admission. But gradually he improved. He started eating again. Soon he no longer needed the nasogastric tube. And in December 2019, we finally shifted gears into a more stable phase. His bloods kept on improving and he became stronger. There were some worries about his chimerism results, but these were more abstract than they were real. On the 30th of January this year, however, we encountered another setback. Larry contracted septic shock from a bacterial infection in his Hickman after a routine dressing change. I rushed him to RCH and he was unconscious in my arms on my arrival. Without going into detail, it was probably the most traumatic incident for us during these last 2 years. I felt like we almost lost him. Yet again, a MET call rang out across RCH. He was pumped with antibiotics, had his Hickman line removed, and spent 2 weeks in hospital recovering. Since then, it's been rather smooth sailing. Larry is once again a healthy, boisterous little boy. He loves drawing, going to kinder, playing Lego, hanging out with his siblings, learning new things, laughing and being silly. He has energy to run and jump again. But we know we're not completely out of the woods yet. It's been a tumultuous and chaotic journey to this point. Over 280 visits to the Royal Children's Hospital. Over 100 blood and platelet transfusions. Over 100 dressing changes on his Hickman line. Over 20 times in the emergency department. Over 14 lengthy hospital stays. 5 trips in an ambulance and 3 MET calls. It is difficult to relay the way that such a disease can completely overwhelm and consume your life. For 18 months, nothing in our family was untouched by Larry's illness. We lived in a state of unrelenting vigilance, perpetual unpredictability, with waves of grief and episodes of terror. We stopped making plans and we stopped telling our kids what we were doing the next day or on the weekend. For from one moment to the next, our lives were upended by a bleed, a fever, unexplained and sudden pain, a problem with his Hickman, a trip to ED, a late night ambulance ride, a piece of bad news to digest. We were forced to live for so long without any rudimentary sense of control or a vision of the future. But I'm also grateful for so much too. I'm grateful for the incredible expertise, care and compassion shown by the doctors and nurses who healed our son. I'm grateful for the creativity and generosity of the kinder teachers, play therapists, counsellors and charity workers who connected with us and Larry and made the experience a little less scary and a little less lonesome. I'm grateful for the incredibly close and enduring friendships that we forged with other families on the Kookaburra ward, each fighting their own fearsome battles against leukemia or neuroblastoma or lymphoma. I'm grateful to our friends and family who listened to us, gave practical support and helped pull us through to the other side. And I'm grateful for the indomitable spirit and bravery of my little boy, a lovely companion on the darkest of days, who just got on with things, who put one foot in front of the other, often while dragging his cumbersome IV pole known as drip robot. My little boy, who was forced to learn at a very early age that the only way to eat an elephant is one bite at a time. Thanks. David, you're just on mute.
I was just going to say the silence there is not because I've not been able to find my unmute button, but I partly was, but it was partly just a moment of reflection from powerful stories. Tommy, his dad's story, and Jessica's story about her boy.
Thank you, Jessica. That was just absolutely overwhelming, and I'm sure David's actually just trying to collect his thoughts, as we all are. But I just thank you from the bottom of your heart for sharing it with everybody. So please bear with us just for one moment.
Okay. So much of what is being shared is so reflective of many of my own patients' journeys and their families, and it's hard to hear. It's important to hear, and I think at the beginning of the session, I said that we all stood to learn from each other, and I think we are. We are running terribly behind time, but I know that you will all agree how important it is to hear these stories, and there's more to come in the following sessions. We've had fantastic participation through the chats, and I would like to welcome all of the panelists for this most recent session back to answer some of the questions that have been posed. So if we could have Lucy and Tommy and Jessica, of course, is on already, back to join in our panel discussion, that would be fantastic. I suppose the session really has been dominated by personal insight, and particularly around the support that families seek from one another, seek from their clinicians and their nursing staff, seek from charitable organisations, and with particular emphasis around the application of transplantation. And there are a large number of of discussions regarding that. Is David Hughes been able to rejoin us?
Yeah, I'm still here.
Okay, thanks,
I
David.
just can't get my camera to work for some reason, sorry.
Thank you. So with respect to transplant, maybe we can ask David in particular. So we've heard from Tom and from Jessica regarding her boy, different types of therapies used at different times. Immunosuppression therapy in the form of antithymocyte globulin, either derived from a horse source or a rabbit source. Other forms of medication used for immune suppression, and then ultimately the application of transplantation. So David, would you mind sharing with us what, and you may mention this in your presentation, that there are algorithms that help follow a particular pathway. Why would ATG, antithymocyte globulin or medication type approaches be used in preference to transplantation, and how are those decisions sort of rolled out in a practical sense?
So I think for children, it's probably a little bit different to the adult setting, David, so you might talk more about that. But in children, if the disease is severe enough that the child needs transfusion support, our preference really is to go straight to transplant. We know that the outcomes for children with a transplant are outstanding, but we know that the safest transplant is a transplant from a sibling donor who's a perfect match. And as I said, only about 20% of people actually fit into that category. So while other transplants like Larry had are safe, they're not quite as safe. And I suppose every time we have to keep bringing it back to the risk and the benefits. So if we don't have a sibling match, we feel that the benefit of trying ATG or immunosuppressive therapy is probably worth a go. But we know that in reality, or deep in our hearts, a lot of these patients will still need to go to transplant. But we just take it back to the risk and the benefit at that particular time point. With acquired aplastic anemia, most of those are immune driven. So by resetting or recalibrating your immune system, there's a hope that we could allow the bone marrow to reproliferate or regrow. That happens in about 2/3 of children to start with, but not many of those children have a truly sustained response. Some of them will relapse again, like Larry did, and have a second round again. And we often try a different type of ATG to see if we can get a better response. But we know that really if you've not responded to the first course, a second course is probably unlikely to work, but it gives us some time. It gives us some time to really prepare, because that, as I said, that transplant preparation is so important to really, and especially for families, to try and work out how on earth this family are going to cope through this process, how they're going to work and get the kids to school. I think it gives us some time to do that preparation. Does that answer what you're trying to ask?
Yeah, thanks, David. So, I mean, it's a complex algorithm, isn't it? So the urgency at which therapy needs to be initiated, the availability of a donor, and as we heard from Jessica, sometimes that's not immediate. The responses to initial therapy and the tolerances to those therapy and the timeframes that underpin that. And as we also heard from Tom and Jessica, those sequence of therapies consume time and are associated with increasing side effects, which makes a very complex algorithm when it does eventually need to come to transplantation. This is not a question that's been put up on the chat, but I am going to ask it with my own personal insight or request of Tommy and Jessica to share their collective insights on this. Tom made mention of the fact that as a 10 and 12-year-old, he doesn't recall much of what was happening, and he's obviously shared powerful reflections from his family. And Jessica made mention of the fact that they spend a lot of time trying to explain and unravel what was incredibly complex and confusing time for Larry. Perhaps if I can start with you, Jessica, how important is it for do you think, reflecting on your own circumstances, to try and keep what was often a very young child up to date with what's going on, the explanations of the complexity, which are often unfathomable for physicians as well as adults? How important is that an element for the delivery of care?
Yeah, I mean, obviously it depends hugely on the age of the child. So when Larry first got sick, he was only 3. So, you know, he could understand kind of very little about what was happening. He really could only understand that he was a bit sick, and therefore he needed various kind of medicines, and he needed to kind of see a new doctor, and you know, he was going to get better. We just had to kind of try a few different medicines first. So we kept it very simple. We didn't talk about bone marrow. We didn't talk about blood either very much, apart from having to explain to him why he had a Hickman line, for example. And, you know, which of course, as many parents do, we kind of called his like super tubies, and that they were really clever because they could mean that he could have blood taken out without hurting him, and he could have medicines put in as well without it hurting him. So he knew the kind of what I think sort of he knew he needed to know at the time, but we were also very careful not to give too much information. So none of our kids ever knew, and still don't know, the kind of the risk that was, you know, playing in the background, the seriousness of what was going on. That would have made we made the calculation as his parents that would have made things a lot more difficult for everybody, for the kids to kind of deal with. And also that they, you know, find it quite confronting, the idea of having someone else's blood put into them. So we also just, you know, later on we described that it was blood, but when he was very young, we described that it was red medicine and yellow medicine. We kind of stayed away from the fact that was somebody else's blood. So yeah, so it was a kind of constant process, which had to kind of adapt to his age. And we're also kind of at pains to always normalize the experience. I think for kind of young kids, they're very aware of wanting to fit in. And we wanted to, you know, we'd always say things like, everybody gets sick, everyone has to see the doctor, you know, to try to normalize the experience. We bought a lot of children's books about going to hospital. We've got a whole library of like Maisie goes to hospital, Franklin goes to hospital, to try to normalise that as much as possible, so that he didn't feel, he didn't feel kind of scared by this thing happening to him that wasn't happening to any other kids that he knew. That answers it somewhat.
Thank you, Jessica. And Tommy, perhaps, you know, a bit of a blur and maybe some relief in not remembering or knowing what all those complexities, but are you willing to share with us how you feel now about discussing that with your folks, and getting some insights into what their feelings were like at that time?
Yeah, I mean, it's hard. I mean, it's interesting discussing it with them now, because I feel like I have a bit more distance to it, where I can be a bit more detached and, you know, maybe cavalier about the whole thing. And, you know, my parents tend to get very emotional anytime I talk with them about it. Yeah, I similarly, kept in the dark for the most part. I mean, I know that my big memory is that when I was that age, I was not, I was very much an indoors kid. I wasn't very athletic and wasn't really interested in running around outside to begin with. So I think for my parents, that was actually like a great relief that, you know, I was pretty happy just kind of, you know, sitting around and reading and drawing and doing all those sorts of things. I think that they felt very relieved that certainly that aspect of it was somewhat easier. And in terms of, you know, the awareness of what was going on, I was kept in the dark, like I said. I do remember maybe about, I can't really remember the exact timeline, like maybe halfway through the entire process, there was this art therapist that they had at the hospital who was doing some work with me. She'd like come around to your bed and you'd do paintings and drawings and stuff. And one day she just said, so how about we do a drawing now where you kind of express how it feels to know that you might die? soon, and no one had made me aware of that possibility at that stage. So my parents came back into the room, and then I said to Mum, like, what's all this stuff about me maybe, you know, about this that I just heard? And then Mum followed the art therapist out the room and went absolutely berserk at her, is my memory of it. That's really the only moment that I can remember. But yeah, I mean, I think my parents are watching this at the moment, and yeah, they tend to get very emotional remembering all this stuff, which is, yeah, it makes it a kind of a strange thing to discuss with them, because I guess I'm able to look at it in a completely detached way, which obviously is a lot more difficult for them to do because they lived it in a much more vivid way than I did as a child.
The Mei-Ling, you're often, you know, near the front line of the just near the front line of helping families come to terms with some of these incredibly free fall moments. You know, the repeated sort of punches, as we've heard, and the can the torrent of bad news ever stop? You gave some practical advice regarding seeking increased support and information. What have you found has helped, particularly between parents talking to perhaps not their very young children, but perhaps that children more in Tommy's age of sort of pre-adolescence, or even adolescence, when they're trying to seek a bit of independence? What's your observations there about how to speak about these incredibly difficult issues and treatments and potential outcomes?
Thank you, David, for the really, really great questions. I feel this is very, very tough because of the cultural issues and a lot of the boundaries behind every family's situation. So I don't feel there's a definite answer to it, but my recommendation is family to family, the differences from the family to family, and we have very good discussion with the parents what exactly their expectations. For example, I just have experience with one Asian family. They don't want to speak a word of a disease to their child, which I respect to. However, at the same time, it's not really the good option for the kids, and that is very hard to balance as well. So for me, is work with the team, healthcare team, to discuss these questions and then to know what exactly is expectation parents wanna let their kids to know. However, we need to consider about the age differences as well. A lot of kids, they are quite bright and young. They know what's going on with their bodies. So for us, sometimes we will have the chat with the patient themselves. They know what's wrong with them. They know they are not well. Sometimes they might feel they don't want to let their parents feel sad. They want to keep the parents feel happy. So they try to pretend they don't know anything. But at the same time, they are looking for, they just stay behind the scene and be quietly seeking for the information, available information. So to me, as a clinical nurse, my role is to talk to the patients at the same time, patients and the family at the same time, to become a bridge in between them, and provided some more support, and for example, psychosocial support, or psychologists, or the doctors, or the team support, just to become a link and to let patients and the parents have a good communication. Yeah, and for I think in Royal Children's Hospital, a lot of art therapists or play therapists, they have been providing a lot of information and, you know, to talk about how are we going to how are we going through the process, through the story time, the songs, or like videos. And I think they are really, really good methods to use. The bottom line to me is, as a clinical nurse, what I like to do is to approach two different groups in different angles, gather their perspective, and then act as a bridge to connect each other.
Thank you. Yeah, thank you for those insights. And you're, as you say, incredibly individualized depending on people's circumstances. Thank you to everybody who's been putting up on the chat the messages of encouragement, and thanks to all of our participants, and recognizing, acknowledging how generous people are and how powerful their stories are. There is a question specifically on the Q&A for you, Jessica, from someone called Emily, and she asked that that her daughter is still going through battles with respect to, doesn't specifically say the diagnosis, but I presume aplastic anemia, just like Larry, and she has always had a hard time with needles and with procedures. And Emily asks, Jessica, from your perspective, what did you find the most useful thing to help him through those times? Emily has a buzzy bee by the looks of things to help their daughter, but what sorts of things would you recommend seeking out with trying to minimize those traumas, which are often multiple and sometimes unexpected?
Sure. I'll start by saying that it's not like we've kind of nailed this at all. Larry still has a lot of anxiety from time to time about kind of needles and procedures. And also that, again, of course, as Emily would know, it changes over time. So, I mean, I think when he was quite young, so probably for the first year that he was unwell, when it came to things like dressing changes or other kinds of procedures, we leaned heavily on distraction. So, there's a lot of moralizing out there about screen time, but that was really the least of our worries at the time. So we would use an iPad and that kind of thing to distract his attention from what was going on, and also as a reward that that was one of the only times really that he was allowed to engage in the kind of games that he was doing on the iPad was when he had his dressing change. So that kind of worked. For us as well, I mean, like the sort of other obvious things like, rewards in terms of lollipops. I think he had his fair share of Chupa Chup lollipops over the last 2 years. And probably additionally, one thing that actually really helped with Larry kind of psychologically was explaining to him a lot about what bravery is. We, would say things like, quite commonly, being brave means that you feel really, really afraid, but you do it anyway. You do the thing anyway that you're meant to do, even though you feel really, really frightened, and it's okay to feel frightened. And he quite quickly started to kind of identify with being brave. He'll still commonly say things like, "I'm the bravest boy in the hospital." And we say, "Yeah, you're the bravest boy in the hospital." And I think for him, it became part of his kind of identity was being kind of stoic in that way, and kind of just pushing through things. So yeah, I don't think there's any sort of magical solution. It was a bit of trial and error and a bit of trying different kinds of techniques, depending on what was going on and his age and how well he was and all those kinds of things.
Thanks, Jessica. There's a lot of questions to get through. I know that we're really running behind time. I think everyone will agree how incredibly useful it is to have this discussion. So I will just keep going for a bit longer. Just coming back to David regarding some of the practical aspects regarding timing and identification of need for transplant, and perhaps some of the follow-up. Let's if we just there's a question here. They haven't given me their name, but thanks for the question. So if a child does go through immunosuppressive therapy with ATG and has not yet moved on to a transplant, the participant asks the question, often they'll have regular follow-up bone marrow biopsies, sometimes very frequently initially and then perhaps yearly thereafter. What are you looking for there? What's the main driver of that very close monitoring?
Yeah, so I suppose we know that some children, when they have aplastic anemia, there's a risk of that disease evolving or transforming to leukemia. And I suppose what we want to do is we want to try and catch that before it really happens. So we look at the genetic makeup of your bone marrow cells to see if there's genetic changes starting to happen, which we would predict would increase your chance of developing leukemia. So oftentimes it's actually not necessarily to look to your response to the treatment, and it's not really looking at necessarily at the aplastic anemia itself, but it's to look at the complications of having had aplastic anemia for a long time, looking for those genetic changes early before they start causing real problems.
So thank you. And as you say, that monitoring is for all aspects. And one of the things that I say to my patients is that just like the eyes are the window to the soul, the blood is only a window to the bone marrow. And if there's any doubt about what's happening in whatever diagnosis of bone marrow failure syndrome it is, the best thing to do is to have a look at the bone marrow. That's where the true truth will lie.
Can I just say one quick thing, just because maybe it didn't become clear in Anthea's or my presentations, and Tommy talked about having bone marrows done with local anaesthetic, and it's been very traumatic. In children nowadays, all this is done under anaesthetic, general anaesthetic. So bone marrows nowadays are not anywhere near as traumatic as bone marrow aspirates, are nowhere near as traumatic as they used to be.
Thanks.
Thank
you for that. A lot has changed over 30 years, that is true. Again, David, if I could just stick with you for a bit. There's been a question here. It was actually put forward ahead of our session as there was an opportunity to do so. And it's been asked again, and I think it really is an important one. There are, as highlighted by Anthea, by Lucy, there's a range of different bone marrow failure syndromes that affect different lineages of the bone marrow. And this question is specifically regarding sideroblastic anemia in a very heavily transfusion-dependent child who's currently 5 years of age. You mentioned in your slide that sometimes there are conditions where replacing the bone marrow helps the bone marrow, but doesn't help some of the other features of that condition, such as Swashman-Diamond syndrome, Fanconi's, for example. Is sideroblastic anemia something where bone marrow transplantation would be considered to be completely curative?
So the problem in sideroblastic anemia is with red cells, and by replacing the red cells, yes, you cure the hematological condition. I suppose just if you're 5 years old and you've been chronically transfused, there are potentially some side effects building up from that in terms of you've had lots of iron. The iron can in itself start causing some side effects, and the transplant won't undo any of that. So it's important that we recognise the limitations of the transplant. So yes, a transplant would potentially be curative for the sideroblastic anemia, but other therapies would also be needed to deal with the side effects of the treatment that she's had so far.
Thanks, David. There is somebody who's put their hand up, which and I'd like them to ask their question if they can. There are a number of other questions which, if I don't get to, we will answer by typing in responses. So, Simon, I think you're back at sort of headquarters there. I think we've got a question from Claire Polly. Can we hear that question, please?
So, Claire, you've been unmuted and you're able to ask.
Claire, are you there? You can ask your question.
I think we're good to move on, David. I think Claire must have.
Maybe, Simon, if you could just see if you could track down Claire and ask so we can hold a question over for later on. Look, a hugely powerful session, really at the true bareness of what this means as a cluster of conditions, and the intensity of therapy, and the huge amount of commitment, hard work, determination, courage that patients and their families demonstrate. The other element, of course, behind bone marrow transplantation in particular are the donors, and I don't want to, there's been actually quite a number of questions regarding donation, and I want to acknowledge their contribution, either potential donors or actual donors, and there are some questions that I will answer by typing responses in the chat. So sorry that we didn't get a chance to go to those, but thank you to all of our panelists in this session for your honest and heartfelt and moving stories and knowledge and reflections. Thanks everyone, and I think we'll move directly on to the next session.
Thanks, David.
Thank you.
I apologise for shortchanging you out of a break, but I think you'll agree that the presentations and the questions have been hugely helpful. Speaking of a break, I do need a bit of a break. So as scheduled, I'm going to hand over the chairing to Nikki Long, who's the CEO of MRV, to welcome you all back and to introduce our next speaker. So I'm going to disappear and...
Thank you, David, and hello everyone. I know that this is quite a commitment this morning, so we really appreciate your attendance, and that we hope that you walk away feeling that you really got out of today what you wanted to. My sincere thanks to Tommy, we haven't met before, and to Jessica, who I've met, and I've also had the privilege of meeting gorgeous Larry. We're so happy for you that your stories are good news stories, and that you've come to us today to share a pretty rocky road, but that you are all in a good and healthy place. It really is great to hear. As you all know, over the last 5 years, we've had a mission to raise funds to find better treatments and a cure. And along that road, it's become very clear to us that we can't do it alone. So all of you online today and your surrounding networks, we're so grateful that you're part of this journey with us and that you share the determination to do better. It's an absolute privilege for me as a CEO to meet not only the clinicians and the researchers, the people in the community that get behind us to volunteer and to help us fundraise much needed funds for our medical research program, but importantly, that I come in contact with so many beautiful families and patients who are personally affected. Every now and then we have not such a great story to tell, and not such a good news story. And our next speaker is someone who reminds us that we need to work harder and never give up, and that we must continue to fight like our dear Maddie Revolt. Brenda Hinchelwood contacted Maddie Revolt's Vision to learn more about what we do and ask us how she could help. But importantly, she told us her story because she wants to raise awareness. Awareness about Fanconi anemia, but also about bone marrow failures in general, and that the fight is not over and that we need to work harder. Brenda works in disability, and she is the mother to Janaea and Ryan, and to her beautiful granddaughter, Milla. She is a grandmother who is closely involved. Thank you, Brenda, for sharing your story. As I said, this is a hard story, but it's one that's real, and it's about why we need to continue our work. And I thank you so much, Brenda, for your bravery today in advance.
Thank you for the introduction, Nikki, and good morning, everyone. I first contacted Maddie Rewalt's Vision last year as the result of a promise I'd made to my son, Ryan. He wanted me to share the story of how Fanconi anemia had impacted our family with devastating consequences. And we shared a sense of urgency in sharing our experience with others, so no other family has to go through what my family has. Fanconi anemia, FA, is a genetically inherited bone marrow failure syndrome, which leaves its sufferers with a much greater risk of developing acute myeloid leukemia and squamous cell cancers in all areas of the body. The risk of developing head and neck cancer is 500 to 700 times greater than the general public. We had never heard of Fanconi anemia until September 2018, excuse me, 4 years after I lost my beautiful daughter Janaea to myelodysplastic syndrome, and 8 months before I lost my son Ryan to liver cancer. I admit that I struggle to understand why they were never diagnosed earlier in their lives, when they both displayed indicators and were seen by many haematologists, cancer specialists, and other medical professionals over their lifetimes. It was the intervention of Dr. Lucy Fox, a clinical haematologist based here in Melbourne and previously uninvolved in Ryan's care, that led to Ryan being tested for FA after his second cancer diagnosis. Subsequently, several months later, we also received a positive diagnosis for Janaea after tissue stored at Royal Melbourne Hospital was tested. It was due to Lucy's realisation that something other than incredibly bad luck was the cause of Janaea and Ryan's illnesses that we finally got the answers to questions we'd been asking for years. FA is, in the majority of cases, diagnosed in childhood. However, there are increasing numbers of sufferers who do not display any obvious symptoms until later in life. The diagnosis of FA came as a terrible shock. I and my children's father had unknowingly passed on this rare genetic disease to our children. A bitter pill to swallow, but at least an answer to our previously unanswered questions. The diagnosis led me to do a lot of reading about FA and gaining as much knowledge as I could about this terrible disease. Although Janaea and Ryan's disease did not present in earnest until they were both of a mature age, the red flags were there and had been waving wildly throughout their lives. Their immune systems had struggled at different times throughout their usual childhood illnesses. A case of chickenpox had Ryan seriously ill in primary school. He had whooping cough when he studied year 12. When Ryan was aged about 12 or 13, it was discovered he had irregular blood counts after having a routine blood test in preparation for a new medication to treat his acne. Thrombocytopenic and neutropenic, he was given his first bone marrow biopsy then. Inconclusive tests followed, as they continued to do over the following years when he underwent these invasive tests regularly. So many incidents outside the norm when they were young, which now in retrospect make me wish I'd done more, pushed harder for answers. At the time, I just didn't know the questions to ask, didn't understand what these seemingly isolated incidents meant in the scheme of their otherwise ordinary childhoods. If there was more awareness of FA, it could have been considered as a potential mitigating factor in cases such as theirs. I'm not trying to apportion blame to any particular professionals. I don't possess a crystal ball, so therefore I have no way of knowing if different treatment regimes would have led to a different outcome. What I'm advocating for is for better treatment pathways and access to genomic testing for future generations. Although the FA diagnosis meant my children's lives were compromised, an earlier diagnosis would have meant they were candidates for early bone marrow transplants before their conditions deteriorated and that they were regularly screened for cancers. Although many of the physical signs of FA were absent, for example, skeletal abnormalities, kidney or other organ defects, etc., in Janaea's case, she had a history of neutropenia and thrombocytopenia, fatigue, dizziness, headaches, hypopigmentation, excessive bruising, and a large area of cafe au lait spots covering her arm, just to name a few indicators. She was diagnosed with myelodysplastic syndrome in 2011, 8 months after giving birth to her first child and a pregnancy fraught with problems. She was only 29 years old at diagnosis and received chemotherapy and ultimately in August 2014, a bone marrow transplant that did not go as planned from the onset. Janaea suffered terribly for the last 6 weeks of her life, She didn't respond to the treatments in a typical manner, and her doctors appeared mystified, constantly trying different treatments to counter her lack of improvement. Her then 3.5-year-old daughter Miller lost her mum, and I lost my daughter on the 11th of October 2014. Janae's treatment at Royal Melbourne Hospital coincided with Maddie Rewalt's treatment for aplastic anemia at the same facility. Janae was in fact in the room just across the hall from Maddie, and she was aware of her, another young woman fighting for her life. I saw Nick Rewalt in the ward common room on a couple of occasions, and as a lifelong St Kilda supporter, I recognised him and was also aware of Maddie's fight. My son Ryan was diagnosed with mouth cancer in March 2017. Ryan was 32 at the time, did not drink or smoke, and had a sister who had been diagnosed with and succumbed to MDS 3 years earlier. Ryan's mouth cancer had taken months to diagnose, due in most part to him not falling into the usual lifestyle, age, or pre-existing conditions categories that would usually lead to such a diagnosis. He underwent a radical mandibulectomy at Royal Melbourne Hospital in April 2017, and after a traumatic period of recovery, went on to have 6 weeks of radiotherapy at Peter Mac. Ryan continued his slow, painful and emotionally draining recovery during the remainder of 2017, including readmissions for infections and eventually the insertion of a gastric feeding tube, as he could no longer orally consume enough calories and was destined for a life where he could no longer enjoy food. His condition improved for a short while before more problems developed, and after another lengthy and confusing period of contradictory diagnoses and inconclusive tests and scans, another bombshell in July 2018, liver cancer. So now we have a 33-year-old man who has scheduled more treatments without taking into account people with FA, which at this point was still undiagnosed, are enormously sensitive to chemotherapy and radiation, and require reduced intensity regimes in their treatment. For this reason, diagnosis prior to initiating treatments for malignancies or bone marrow transplants is critical. Discussions with geneticists and medical specialists after the FA diagnosis in September 2018 have indicated that his treatment regime would have and should have been modified, again leaving me questioning if this could have reduced his suffering. Ryan died as a result of his liver cancer on the 26th of May last year. The saying knowledge is power was first attributed to Sir Francis Bacon in 1597. In the case of FA, this could not be more true. Had we had the knowledge my children had FA, they could have been candidates for early bone marrow transplants before their illnesses progressed. Had we known, they would have had regular cancer screening, and it wouldn't have taken months and months for Ryan to be diagnosed with both his cancers. Had we known, their radiation and chemotherapy treatments would have been adjusted and possibly not added to their suffering. And now, because we know, my granddaughter Miller has been identified not as a sufferer, but as a carrier of the faulty FA gene. Unlike me, she will have the knowledge of her potential to pass this gene on to her future children and the means for her future partner to be tested for the gene. She's only 9 years old at the moment, so this is a conversation her father, stepmother and I will be having with her in the not too distant future. For the moment in her short life, she's been through enough. She's lost her beautiful mum, who she is the image of, and her adored Uncle Rai, but she will have the knowledge we did not. To leave a legacy for my children is the reason I'm here. Ryan and I had several conversations throughout the later stages of his illness about raising awareness of FA. He was particularly concerned with the testing for FA before bone marrow transplants, due no doubt to his witnessing what his sister went through. He had in fact taken himself off for yet another bone marrow biopsy without my knowledge after her death, telling me later he hadn't wanted to worry me, but being terrified about the possibility he would succumb to the same fate. I'm no medical professional, far from it, but it is my experiences throughout my children's illnesses that have led me to see a tendency in the medical professions to treat the symptoms they are presented with without considering the cause. Compiled from my reading and learning about the condition through organisations such as fanconi.org and the National Organisation for Rare Disorders, I'd like to advocate for FA to be considered and tested for in the following scenarios. In any patients presenting at a young age with aplastic anemia, myelodysplastic syndrome, squamous cell carcinoma, a personal or family history of cancer predisposition, or a history of cytopenias or cytopenias coupled with congenital abnormalities. Prior to bone marrow transplantation for any patients falling into the categories outlined above. In patients suffering with excessive effects from chemotherapy and radiation. In young patients presenting to head and neck cancer specialists with oral or esophageal cancers. And in young patients presenting to liver cancer specialists with hepatocellular carcinomas or liver adenomas. Ryan did a lot about raising awareness of FA through social media before his death, which is another story about my amazing son that I won't go into now, or I'll be here all day. His partner Dean and myself are doing what we can to continue to raise awareness through fundraisers and talking to people about FA. The loss of my children has left me devastated and still questioning why us. The focus of my attention now is what I can do to change outcomes for others. And this is why I reached out to Maddie Rewalt's Vision and to those of you listening for help. Please learn about FA. Please tell others about FA. Ask your doctors and specialists about FA and help us to get the awareness to those who are responsible for treating the sufferers. I'm told there are many more out there. I'd like to thank you all for listening to my story and to Maddie Rewalt's Vision for the opportunity to share it. I know we have a long way to go in improving outcomes for people suffering from bone marrow failure syndromes, but the fact we're all here today gaining knowledge and insight into these diseases gives me hope for brighter outcomes for sufferers in the future. Thank you.
Thank you, Brenda. I said at the beginning, you're a brave mum, brave granny, but I think everyone will agree that you know, what you've spoken to today and shared with us is just extraordinary, and we're terribly sorry for your loss. And as you know, we want to hold your hand in trying to raise awareness and to find solutions for the future. I understand everyone might be quite moved by your story now, and you know, just to take a few moments to reflect. The back half of today is very much about hope for the future and what we're working towards. And David will introduce our next speaker, Andrew Deans. But it's providing us with the optimism for the future and why we want to continue to raise funds to support people like you've heard from today and the extraordinary research community. We're very focused on finding next generation solutions, not only in raising awareness, but also to really uncover and discover what better treatments can see children not spending so much time with their families in and out of hospital, and not to have so many unknowns in the future. Just a reminder before I hand over to David to please visit our website. There is so much more information on there to look at, and there's also ways in which you can sign up to help, such as volunteering. So thank you very much for listening, and we really appreciate your ongoing support. Thank you, David, and thank you so much, Brenda.
Thanks, Nikki, and yes, my thanks to Brenda too for sharing her story and being so brave to come and share it with us. And there are many postings on the Q&A chat expressing everybody's thanks for sharing that story and recognizing the enormity of your loss and the enormity of your bravery. So thanks to everybody for sharing your views there. As Nikki has said, the next two presentations and will be followed by a panel discussion with more opportunity to answer some questions. Really focus on the future, focus on the opportunities that there may be for us to deliver better care, more precise care, understand opportunities to not make the presence of these disorders fateful in their outcome. And the first of our presenters talking about future developments is Associate Professor Andrew Deans, who leads one of the world's largest genomic stability research centres based here in Melbourne at the St. Vincent's Institute, not far from where I'm sitting right now. And he's really been a leader in understanding what it means to have genomic lesions that lead to abnormalities of hematopoiesis and other cell processes. And one of the very first people that MRV supported was Wayne Krishmani, who's also one of the participants today, who works in Andrew's lab. And so Andrew has a deep and long history of trying to understand what makes cells tick and what protects their genome from further damage. And I'll hand over to him now to share his thoughts on his research and the future developments for bone marrow failure syndromes. Thanks, Andrew.
Thanks, David. I'm assuming that is shared okay. It's a great pleasure to be talking at this symposium, and I really just wanted to start by thanking Jessica and Brenda for sharing those wonderful personal stories, or not wonderful, terrible personal stories. I have a 1-year-old and 5-year-old myself here at home with me, and I've been kind of sitting here bawling my eyes out with hearing your reflections, and I really want you to know that your stories are some of the most powerful stimulus to researchers like me in trying to make a difference. You should also know that MRV has massively boosted the capacity of Australian researchers to make big breakthroughs in understanding bone marrow failure, but more importantly in driving new technologies for its treatment, like I'm going to talk about to you today. So I wanted to start with a quick nod to the current therapies for bone marrow failure research, which already do have a lot of success. And I want you to remember that less than 50 years ago, these treatments were really science fiction. And so some of the things I'm going to talk to you about today might seem that way, but actually they really are possible. It's only been 30 years since immunosuppressive therapy and hematopoietic stem cell transplantation became widely used. Here's an example from the Fanconi.org website which demonstrates really how the life course has changed, for example, in patients with Fanconi anemia. The average life expectancy pre-1990 was actually less than 10 years, but now Fanconi patients on average live well into adulthood, and actually one of the major causes of death now is the head and neck cancer that we just heard about. So medical research into genetics and bone marrow transplantation has driven this massive improvement, and so I think Maddie Rewald Vision has really made the right decision in supporting driving this forward. And so I'm going to be talking to you today about cell and gene therapies, and the reason we're talking about these is because these will be a replacement for bone marrow transplant. And this is because we've already heard that bone marrow transplant has some problems. And what are these problems that mean it needs replacing? Well, we've already heard that donors are really hard to find. It requires this toxic conditioning that means a lot of time is required in hospital, ongoing immunosuppression, and then obviously this, we haven't heard much about today, but this really horrible condition called graft versus host disease and cancer later on in life. And it's really the immune system that's the major driver of all of these problems, and comes from issues within the immune system. So the immune system is part of the blood, derived mostly in the bone marrow, and it's specifically established to prevent foreign invasion, including from viruses like COVID-19. That is the reason I'm talking to you from home today rather than in person. And for COVID-19, for example, the infection occurs initially in the airways. Antibodies and the immune response originates in the bone marrow, and then this attacks the infection and prevents it. Something similar happens with organ transplant, taking a liver from one patient, which I'm here calling the graft, into another patient being the host. It's the liver itself that is recognised as foreign, and it becomes attacked by an immune response. So this is somewhat ameliorated by careful matching of HLA markers. So that's why we've heard a bit about trying to find people who have the correct match for transplantation. And that limits this immune response, but it still doesn't completely remove it. However, when we transplant the bone marrow, we're actually transplanting the entire immune system of the graft, so that the donor is giving their immune system to the patient. So different to other types of organ transplant, for bone marrow, a major problem is actually the graft itself attacking the host, and we get immunological responses to the organs, which are then recognised as foreign. In a fraction of transplant recipients, this is highly toxic and can cause death by something called graft versus host disease. But what about if the recipient was also the donor? This would help to overcome all of these problems because, well, you wouldn't have to search for a donor. You wouldn't have to undergo this really horrible, long hospital stay of conditioning. No ongoing immunosuppression is required because the patient's cells come up from themselves, and the host is tolerant of a graft from themselves. But this is where stem and cell gene therapies come in, but certain technologies are going to be required to actually make this happen. There are a few different approaches. One, we can create bone marrow cells from the patient's own cells. And this way they're invisible to the immune system of the patient. And this is kind of the concept of a self-transplant. An alternative approach is to create a universal graft. So a set of bone marrow cells that we've engineered to actually be available off the shelf to give to any patient. And these would be created in a purely laboratory cell culture, for example, or using an animal host in a process known as xenotransplantation. Xenotransplantation is more advanced for research into xenotransplantation is more advanced for whole organ transplants rather than blood, so I'm not going to talk about it today. But all of these approaches require manipulation of the genes of cells using cutting edge technologies, and a lot of them technologies that don't even exist yet. So an example, the first of these technologies is gene therapy. This technology has most of its potential currently in bone marrow failure syndromes. We've already heard about Fanconi anemia, and actually this is the example that I'm going to talk about today. It's a topic of my research lab's interest at St. Vincent's Institute. This is where, but it's also applicable to any other genetic cause of bone marrow failure where there's a gene mutation. We heard some of the others in earlier talks today. Now, Fanconi anemia results from inheritance of Fanc A mutations or other Fanconi gene mutations, and this means that every cell lacks a normal Fanc A gene. As with all of these inherited bone marrow failure syndromes, the problems actually start happening pre-birth. We can actually see reduced numbers of blood stem cells early on in life. Normally pre-birth, the number of stem cells in the bone marrow increases and stays high across the life. But in Fanconi anemia, the number peaks prior to birth and then runs out starts to run out an average of 5 to 10 years of age. So we actually need to get these cells out quite early on in life if we're going to want to use them for gene therapy. The cells that we need for gene therapy are the same as those that are used in transplantation. What I've shown you here is a concept of a blood stem cell, which has a capacity to generate all of the other red and white blood cells of the immune system. But in particular, we're interested in CD34 positive cells, and a gene therapy trial in Fanconi anemia has actually already been performed in Spain, where they've taken these CD34 positive cells from Fanconi anemia patients, cultured them briefly outside the body, and then introduced a virus which contains a normal copy of the FANK gene back into these cells in culture. And they're then taken and inserted back into the patient. And wow, this actually really works. And this paper was published in Nature Medicine just last year. And this is results from 4 children who were given FANK gene therapy. They had successful engraftment of edited cells, or sorry, of gene-corrected cells with a donor where they'd had this viral normal copy of FANK inserted. They had no conditioning and no immunosuppression. And you can see, for example, here in this patient, following 30 months after transplant, close to nearly 60% of their cells actually now contain the gene-corrected bone marrow. It's a bit lower in some of the other patients, but if we look more closely down here at the bottom at the leukocytes, what we're looking at here in red is the uncorrected leukocytes, so the original cells which were taken from, the uncorrected mutant cells. Even after transplant, these cells continue to decrease in number, and these patients would have gone on to reach bone marrow failure at some point if they hadn't had the transplant prior to their bone marrow failure. But what you can see in the green is that the corrected cells are actually starting now to replace the mutant cells. So this exciting finding means that there's actually the potential to stop bone marrow failure happening in Fanconi anemia, but also in other inherited bone marrow failure syndromes. And perhaps using gene therapy, we can actually prevent bone marrow failure from even occurring in the first place. But gene therapy does work but, in both Fanconi anemia and other genetic disorders, but it requires lots of these CD34 positive stem cells to be present. And that's not always the case. If a child or an adult presents already with bone marrow failure and no pre-existing diagnosis, then these cells may not be available prior to the onset of bone marrow failure. Virus delivery itself has some risks, which have mostly been reduced, but they are still around. It's incredibly costly, and it actually hasn't been proven for every gene. And it works quite well for FANK, but there are likely many other genes that cause bone marrow failure where this approach would not work. So this is where a new technology comes in, known as gene editing. Gene editing is a little bit different. It's a version of gene therapy. And to explain gene editing, I'm going to use an analogy, and I want you to think of a gene as a sentence that gives an instruction to a cell. And we all know how sentences convey information in language, and something similar happens in the genetic language in how instructions are given in cells. But in this example, I hope that you can appreciate how significantly the meaning of this sentence has changed just due to a one-letter alteration. In gene therapy, an entirely new copy of the sentence is inserted, but the underlying mutation in those cells actually still remains. And in some cases, this can be problematic to the treatment of the disease further down the line. In gene editing technologies, we actually edit the sentence or edit the DNA within the genome so that the correct meaning of the sentence is restored. And for most genes, this will have a better outcome for the cell than inserting this whole extra copy of the gene or the sentence. Gene editing's in its infancy compared to other gene therapies, but it's my feeling that it will eventually supersede it. And I wanted to show you some exciting results from Astrid Glasser, who's a postdoc in my lab at St. Vincent's Institute, who's been using a brand new technique that was only discovered around 6 months ago to gene edit cells in culture. And she's used a specific gene marker that changes the cells from green to blue. And as you can see using this analysis, when unedited, we begin with unedited cells shown up here. The cells are green. However, we get close, over 60% of these cells become edited. And if we can replicate this in CD34 positive stem cells, which we're now trying to demonstrate, then gene editing could really be closer to reality than we realized. And we're trying out this approach in Fanconi anemia as well. So gene therapy or editing are exciting technologies for treatment of inherited and possibly acquired bone marrow failure. But there's also this problem of what if you don't have enough CD34 positive stem cells to begin with, either for editing or for this type of self therapy. And the final technology that I want to talk to you about today is induced pluripotent stem cells, because this technology allows you to generate CD34 cells from other types of cells in the body. This technology adds an extra step to the self-transplant concept. And instead of isolating CD34 positive cells from the bone marrow, we make CD34 stem cells from other types of cells, for example, skin or blood, or other cheek swab, for example, taken from the patient. A combination of these genetic factors can be added to these cells in culture, and it reprograms them back to an embryonic-like state. And then this allows them to be turned into any one of different types of cells which make up our bodies. Significant research, including that funded by MRV, is actually trying to figure out how to carefully turn these cells into large numbers of these CD34 positive cells that can be used for transplantation. I'm not going to talk more about this technology today, other than to say that there are a few published studies out there demonstrating that we can fully restore bone marrow function in mice from cells made from induced pluripotent stem cells. It hasn't yet been demonstrated in humans, but Australian researchers are leading the field in this area, and there'll be some really big breakthroughs published soon. So in summary, stem and gene therapy is a really exciting way of overcoming these immune-related problems to bone marrow transplants. But for now, I'd like to also point you in the direction of a trial that you can enroll in that will help us and other Australian researchers develop gene therapy or gene editing and other technologies for bone marrow failure research. Please check out FASA.org.au, which is the newly established Fanconi Anemia Support Australia. Or you can contact me by email, and I can point you in the right direction. Thanks for your attention.
Thank you very much, Andrew, for so thoroughly explaining such a complicated area, but with such excellent analogies. And as Andrew has mentioned, the MRV and the Centre for Research Excellence has a spin-off subcommittee specifically seeking ways to bring gene therapies and novel cellular therapies to the treatment of bone marrow failure syndromes. And Andrew, via Wayne Krishmani, who I mentioned before, is now the chair of that subcommittee, will have a significant influence over that research initiative. We are, I think I've said this all morning, running behind time, so I might just move on back to Lucy. Lucy won't mind me not giving her a formal introduction again, but she's going to share with us some of the local initiatives regarding clinical trial opportunities as novel therapies for bone marrow failure syndrome. So back to you, Lucy. Thanks very much.
Okay. Hello again, everyone. I'd first like to thank all the patient and family stories and just echo everyone else's comments about how powerful they are. They truly do spur us on to make things better. And so in this second talk, I'm going to present some exciting new projects and collaborations that are occurring in the area of bone marrow failure in the hope of improving the lives of all Australian patients and their families. Listed on the previous page were 6 separate projects, sorry, I'll just go back, that we're actively working on in the area of bone marrow failure syndrome research. They're listed individually, but several of them are very closely related. Several of them are supported by Maddie's vision and their associated Bone Marrow Biology Centre of Research Excellence. And I'll recognise this as I go along. I'll start with the aplastic anemia and other bone marrow failure syndromes registry. This registry is housed at Monash University at the Transfusion Research Unit. The steering committee is chaired by Frank Firkin, and the registry is overseen on a daily basis by Erica Wood. The registry was established in 2013, and in recent years we've had the wonderful support of MRV. This year we are changing the name of the registry. While it has always been open to the enrolment of patients with the traditional bone marrow failure syndromes, the patient capture has been skewed very heavily towards immune-mediated aplastic anemia. And so we've changed the name to reflect more clearly that we want to capture all patients with all kinds of bone marrow failure syndromes, from those traditional diseases mentioned earlier today, right up to the new inherited diseases that have only just been published in the literature. Pictured here is the accrual of the registry, and we now have 188 patients enrolled. And we really expect this number to climb pretty quickly, given the number of sites that we now have on board, and particularly as we progress the other projects that I'm about to present to you. You may have seen this slide rotating earlier in the morning. These are the sites that are recruiting patients. The Northern Territory is the only state not represented currently. And if you're a patient with any of the diseases we've discussed today being cared for at one of these hospitals, then you are able to be enrolled. If you're in the Northern Territory or you are cared for at a hospital not listed here, please send an email to the address listed there, and we'll do our best to see if there's a way that we can facilitate things for you. Located here are the patients enrolled at each site. I'll speak about the orange diamond study patients shortly. And looking at this graph, we know that we are not capturing all of the patients presenting at these hospitals that we have on board. And this is predominantly due to the busy workload of the clinical staff, but it's often because of the diagnostic dilemma that patients present when they first walk through the door. It can take time to work down if you're going down an immune aplastic anemia pathway or a disc keratosis pathway. And so while your doctor is focusing on trying to work out the diagnosis, sometimes enrolment on the registry can be forgotten. And we ask for patient help in reminding them to do so. The registry consent is opt-out. That means there are no forms to sign. Rather, you're provided with a pamphlet by your clinical team. And if you don't want to be involved, you can let us know. And for interested patients, in the first instance, speak to your doctor about getting you on board. And for doctors and other clinicians and hospital staff on the line today, we've got a brand new REDCap database. Many of you have been issued with new logins and access, and we're in the process of rolling that out currently to all of the sites. So please do email us again on that address if you have any questions. So moving on now to the biobank. Earlier this year, Maddie's Vision announced a competitive grant process to select an organisation to establish and maintain a national bone marrow failure biobank. In June, it was announced that the successful applicant was a combined submission by Biobanking Victoria and Monash University. A long-established institution, Biobanking Victoria, led by Professor Melissa Southey, will be responsible for receiving and storing the samples, and they will be able to provide these samples to approved researchers. And these samples will be particularly powerful if the researchers can know some de-identified characteristics of the patients, such as what their bone marrow looked like and what treatments worked for them and what didn't work. So these details are going to be kept in the aplastic anemia registry led by Professor Wood that you've just heard about. So this project's in its infancy. We're currently developing the protocols such as what samples to obtain and when, and patients will need to consent to this process. So you'll hear about this before you, to sign up for this before we obtain your samples. And all patients with diseases that I've spoken about earlier today are eligible to participate. Okay, moving on to the DIAMOND study. So this is a clinical trial open to adult patients with aplastic anemia. The drug under investigation is avatrombopag, which stimulates blood cell production. It mimics a natural hormone. You may have heard of L-trombopag. This is the same kind of agent. There are two groups of patients being studied: newly presenting patients and patients who have failed, or relapsed or otherwise failed their previous therapies. And you can see that we have 14 patients signed up to study so far, and we're very keen to enrol more. This is a trial that's using the infrastructure of the aplastic anemia and other bone marrow failure syndromes registry. And all patients who are on this study are enrolled in the registry also. We've got 8 sites open with more to come, and any inquiries can be directed to that email address. On to the Embrace study. This is something that we are undertaking at Peter Mac, and we're hoping to offer this to patients from other sites and states soon. This is really building on our Melbourne Genomics Health Alliance Bone Marrow Failure Flagship project, where we did extensive genetic testing in bone marrow failure syndromes. And along the way, we learned a hell of a lot and worked out that there are quite a few things that we can improve on in caring for bone marrow failure patients. And that was in fact how I met Brenda and Brenda's son, Ryan Hinshelwood. We want to offer a comprehensive care model for patients with bone marrow failure syndromes right from the time of diagnosis, when genetic testing and counselling is hugely important. We want to continue something that we're already doing, national multidisciplinary team meetings where we include the treating doctor and we talk about the genetic results and what they mean for that patient. We want to make sure that the treating doctor is aware of the registry and the biobank and any clinical trial opportunities. We want to provide detailed disease-specific management plans, which involve things like when to get an eye check, when to get a skin check, when to get a head and neck check for an early cancer, when to get a colonoscopy. We want to help people on how to surveil for early leukemia development and how to interpret those acquired mutation testing tests where relevant. And we want to help people with their fertility discussions. The study team is listed there on the left, and you can see we have Anna Jamolowitz, a genetic counsellor, and also Associate Professor Paul James from the Familial Cancer Centre. Stage 1 is now complete, where we interviewed key stakeholders to find out what works in the current system and where we can improve things. And we're now moving to stage 2, where we're going to implement this locally and then go on and offer it around the country, hopefully very soon. So this is a Maddie's Vision supported project, and of course we are extremely grateful for that. Okay, I'm going to speak now about Fanconi anemia. So there is a trial using the drug metformin in Fanconi anemia. And some of you attended our first bone marrow failure scientific symposium last year. And we were privileged to have Professor Akiko Shimomura from Harvard and Dana-Farber Children's Cancer Centre here to speak about this study. So metformin is a cheap oral medication that's been around for quite a while, used for diabetes, polycystic ovary disease, and it's got a long safety track record. And it's thought that it can improve blood counts in Fanconi anemia patients. So the Boston team have been recruiting young Fanconi patients with low blood counts. And unfortunately, COVID in the States has really put a stop to their recruitment. So they've taken this time to analyse their data. And they've been quite pleased with the results that they've had so far. They've been very encouraging in terms of safety and effectiveness. And so what they are trying to evaluate at the moment is if they can just stop stage 1 because of the good data they've had so far and just move straight on to stage 2. And that's where we're hoping to come on board. The team is considering expanding their inclusion criteria. So it may be for patients outside of this age range there. It may be for patients with less severe blood counts than what they did originally. So we, and what we're discussing with them, the feasibility of having 2 Australian sites, one adult centre and one paediatric centre, and we would hope to offer this to patients from around the country. So what COVID has forced us to do is to be more accepting of healthcare from a distance, and telehealth is now a daily thing for us. So for the Fanconi patients on this meeting and the doctors on the line, just if write me an email if this is something you would be interested in this, because when we do feasibility assessments for clinical studies, it is a lot easier if I can say I've got 10 or 20 potential patients who would consider this. And again, Maddie's Vision and Simone Neal have been, including Simone Neal, have been really helpful with this study, and we're so grateful to them for their support. So the final thing I briefly want to talk about is this group called CCCTAA. So this is a group of clinicians and scientists who are interested in disc keratosis congenita and other telomere biology disorders. This is something that we are getting involved in, and we're trying to work out how best to be able to share our Australian experience for those patients who are happy to do so. So this group wants to promote studies of telomere biology and develop clinical trials. And part of this is working out where the patients are and what the nature of their disease is, what the genetic mutation they have. Again, if this is something that applies to you, please send me an email, and because I'll add you to my list of potential patients who could contribute their experience to this international data set. So in summary, bone marrow failure syndrome research in Australia is a highly collaborative field, thanks to the work of Maddie's Vision and the Bone Marrow Biology Centre of Research Excellence. There are many innovative and exciting projects, some of which I haven't had time to mention to you today. There is lots of momentum, lots of passion, and importantly funding, which we cannot do without. Please consider the registry and the biobank. Please spread the word. We need to know where the patients are and the specifics of your diseases if it's going to be feasible to bring international studies here and indeed open up more Australian studies. So we are really keen to stay in contact and keep all of these exciting conversations going. So with that, I'd like to finish, and thanks to all of our collaborators and of course you, the patients. Thanks, David.
Thanks very much, Lucy. Again, a huge amount of information to cover in a short time, but hopefully give all the participants some insights into the multi-pronged approach that MRV has taken. Just one little thing about the Centre for Research Excellence: every single fellow, project holder, clinical trial that is funded by MRV gets automatic membership of the Centre for Research Excellence. It's my great honour to be the director and chair of that, and to get these hugely inspiring researchers and clinicians around the table, probably more frequently than they have time for, to look for collaborations. And many of the projects that you've heard about that Lucy's covered today is a direct consequence of that, or related undertakings. I would just like to get all of the speakers back to video on, if possible, for our last panel discussion and Q&A session. And really thank everybody in all of the sessions for their expert, honest, and beautifully pitched presentations to what is a very mixed audience, but an audience that I think, judging by the comments and questions that have come through the Q&A submission portal, have really found the sessions hugely helpful, both factually, but also psychologically and socially. It's a little hard to know what to do with our time, but I think we'll set aside at least 10 minutes or so for some questions to the panelists. Nikki has joined us as well, and Lucy and Andrew and Brenda are online as well. I did want to perhaps just come back to a concept or an issue or an observation that was made earlier in the day, and there's a question here which I'm going to ask Andrew and Lucy to respond to, but also just wanted to share this observation or this comment. because this is true of many of the patients that we look after, many of the families that we're engaged with. And this person who hasn't given their name, but thank you for the submission, their observation is that it's very difficult transitioning from a child to an adolescent to a young adult. And that's so fundamentally true of bone marrow failure syndromes, where they may initially present, perhaps not be diagnosed, but present as a child, become more obvious as an adolescent, and then transitioning that autonomy through to a young adult. And this particular person made the comment that their daughter was 8 when originally diagnosed and is now 20, with still some ongoing issues, which of course underpins many of the comments that we've heard from clinicians and family members and patients, is that this is a long haul circumstance, one that is filled with many ups and many downs. And they make the comment that it's a tricky transition, and I could only just pass on that message from this person. But they did have a question, which is what I would like Lucy and Andrew to share some views on. So this person's daughter, it's hard to tell whether a mum or a dad, but this person's daughter was originally diagnosed with aplastic anemia at the age of 8. And then Lucy made some comment on this during her presentation, and Andrea also commented on this, had more prominent features of PNH, or paroxysmal nocturnal hemoglobinuria complex disorder, which we don't have time to go into now, but that became more obvious at 16, and is now on maintenance therapy for PNH. Transfusion independent, but the question really is what does that represent in the way of their bone marrow function? What are the risks that something further might happen? And the specific question is, should transplantation be something that's considered earlier rather than later? So we just really want to come back to that idea of the changing genesis of the bone marrow. And I might just start with Lucy first.
Sure. So what I didn't have time to speak about is the nature of this almost spectrum. We don't consider aplastic anemia in a silo. There is this associated condition, PNH, where, like I said, 50% of aplastic anemia patients have a small PNH clone when they're diagnosed. And a handful of them, the disease can change its stripes, if you like, and that clone can increase in size over time. And by that I mean the percentage of the cells increases over time, and that can manifest in different ways. And you might patients may become eligible, and you can see there for that treatment Soliris if the disease really does change its spots into something different. So that is something that haematologists are looking out for. They're checking in on patients for their PNH clone level every so often, and we speak about this idea of you need to, sometimes you need to treat both aspects of the disease. You need to treat both the PNH aspect, and sometimes people need some concurrent immunosuppressive therapy to treat that other aplastic anemia therapy that is still going on. And if things are going well with the Soliris, like it sounds like they are, if this young woman's now not requiring blood transfusions, that's great news. And it doesn't. But what can happen is sometimes the other counts can go down, or sometimes the Soliris isn't as effective as what it was, and sometimes then we do need to look at moving to a bone marrow transplant. But that can be a bit of a difficult time, because that's not sometimes that works and that's great, and sometimes it is a difficult time with having to deal with both disease processes during a transplant. I'd also say that there are other drugs coming onto the market for PNH, different drugs to Soliris, which is the hope of other agents should that drug stop working down the track. I'll finish there, David.
Thank you, Lucy. And Andrew, I just wonder maybe if you could just share your insights on the basis of that question regarding clonality and changes of clonality and the benefits, therefore, of novel therapies such as gene therapy or gene editing to prevent that clonal evolution.
Yeah, look, I have to be careful answering these kind of questions because I'm not a clinician and I don't have the type of insight that you and Lucy have. But I certainly can give a perspective in terms of gene therapy. As I mentioned during my talk, I think the earlier that we can take cells, perhaps pre-clonality, pre-complete failure, the better you have as a starting stock for working with. But this is not therapy that's widely used and available at the moment. So the general feeling is that it's up the clinician together with the patient decide when the suitable time for transplant would be. It's my understanding, and at least for a lot of Fanconi patients, many of them don't actually end up having a transplant because of acquired reversion mutations that is kind of protects them from bone marrow failure. So you've got to be careful to rush to a transplant because we've already heard from some of the families that it's a pretty tough thing to be going through. And if it turns out that there are other options, then perhaps waiting can be better. So that's my non-clinical view. And from what I've heard from speaking with lots of families and lots of clinicians, at least in the Fanconi anemia space.
Yeah, and just subsequent posting is that question was from Melissa. So thanks, Melissa, for sharing that complex area and perhaps something that we might be able to pick up on later offline. I wonder if I might just ask Nikki and Brenda a combined question. So Nikki, you spend a lot of time speaking with families and with donors, and sometimes those donors have personal experiences and sometimes they don't. And Brenda, you've heard how challenging diagnosis has been, how incredibly grateful we are to have advances in techniques that allow clearer diagnoses and prognoses to be had. And the combined question that I'd like to ask you on behalf of the participants is, how important is it in your conversations to donors and families to hear of the developments of research and the dedication of donors and bodies like MRV putting funds into answering these questions and to doing what I posed right at the beginning of today's session, re-looking at ways of doing things? Perhaps we start with you, Brenda.
Well, it's critically important. There's been so many advances, even since we lost Janaea. Like I said then, we'd never even heard of Fanconi anemia, and organisations like Maddie Rewalt's Vision have been very supportive and helped me find the answers to the questions that I didn't know. Like the advances that I've seen today in identifying sufferers with Fanconi anemia, as explained to us by your panel, are a great relief to me in knowing that possibly these advances are going to help other families not travel the road that mine has. So it's been really great.
Thank you so much, Brenda. And Nikki, in your conversations on behalf of MRV with donors and families, how important is that message getting back that, you know, MRV now supports 24 different research projects, and there are many others which are beyond MRV's specific influence that we've sort of brought together?
It's critically important, David. I also want to acknowledge that Fiona and Joe are online today, and without their bravery to step up to the plate along with Nick and Alex to talk about their story and what they experienced with Maddie, none of this would have happened. And here we are 5 years later. It's not by chance that we have 24 projects in the making under a Centre of Research Excellence. We started out from day one with a strategy, and it's really important to communicate to everyone online today, as well as our entire other community not online today who fundraise on our behalf, that that strategy has meant that during this COVID period, we're able to honour all of our research projects right through to the end in a couple of years' time, because we set out with a plan, we've set out with building blocks, and we're slowly but surely, well actually I think we're rapidly building those blocks and really quite determined to make a difference in a short period of time. We look at other areas of medicine where so many leaps and bounds have occurred because there's been a big investment and injection, and that allows things, ideas and innovations to accelerate. So being able to communicate that we have a plan, that we're very determined about that plan, we've got the right governance, we're involved with the right clinicians, researchers, and importantly, engaging with the community that this most impacts, which is families and their loved ones. And so, you know, we have a strategy that we're very confident about that is already making a difference. And every dollar where possible goes towards funding medical research and having impact.
Thanks very much, Nikki. Coming back to some sort of specific biology and science questions that have been posted, and I'm really sorry if I don't get to everyone's question. Lucy, what's the potential role for single cell sequencing from a marrow to understand perhaps more of the clonal complexity? And we have a question here from someone specifically with Swashman-Diamond syndrome.
Yeah, so this is a newer testing methodology, and what it does is, as the name says, it allows people to look at one cell or a handful of cells of a patient and really drill down on that particular cell, and it provides a huge amount of insight into things, the clonal evolution or moving of the disease towards a leukemia process. And it is something that goes on in a research capacity here at Peter Mac, where I am today. It's been done quite a lot in the blood cancer space, but I'm not aware that anyone is doing it yet here in Australia for Swashman-Diamond syndrome. But they certainly the people I referenced over in Boston, Akiko Shimomura and Coleman Lindsley and Frederick Tsai, they are doing that kind of work, and that's how they are focusing on things like those TP53 mutations and trying to work out, you know, what is it that makes people become unwell, and see if we can track it and try to work out if we can prevent that process.
Thank you, Lucy. So we've really run out of time. I know that there are some unanswered questions. I did want to share with the panelists a couple of comments that people have, and with everybody who's still online, a couple of comments that people have made. We've had a response from Rob. He answered a question earlier on, but he just wanted to share with everybody that he is actually a participant on the Diamond study, and through that study and the great work of Steve Ting and his collaborators, has had access to a drug called avatrombopag, which has an important bone marrow stimulating effect. And he just wanted to share the news that his blood counts are getting better, and he really just wanted to give thanks to everybody for the availability of that trial. He has his fingers crossed. And sort of related to that is a comment and a question from Emily, whose young daughter also has access to one of those drugs, a slightly different one called L-trombopag. Who makes up these names? I've got no idea. But she asked the questions, will that be enough to cure her daughter? And the short answer is we don't know. It doesn't mean to say that she's absolutely destined to have a bone marrow transplant, but close monitoring and a close understanding of her bone marrow biology will be important to help answer that question, and working with people like Anthea and David in your team will be important. And I'm really sorry that we haven't had a chance to get that more fully discussed. I think we've almost covered all of the issues. I'll speak on behalf of the team who are putting together the biobank, because Karen asked the question, is it possible to store cells for future therapeutic options? And the answer in the biobank is no, currently, but possibly through the Gene and Cellular Therapy Subcommittee, opportunities for stem cell collection, manipulation, or even excitingly pluripotent stem cell biologies may be a thing of the future. That's currently not something that the biobank can offer, but it's all part of the broader strategy that you've heard Nikki talk about. It's 1 minute to 1. We are really significantly over time. It's been a hugely insightful, heartfelt, emotion-filled, data-filled morning and early afternoon. I think we do, if my background technical team have advised me correctly, I think we have somebody who would like to speak with us all. So Simon, is Nick available? Perhaps as we try and there he is. Okay. So thanks for joining us, Nick. I know that, like all of us, you have an incredibly busy schedule, but thanks for joining us, and I'll hand over the microphone to you for a few words.
Yeah, thanks, David. My role is really quite straightforward. It's basically just to thank all of you, to thank everyone that's attended our very first patient and family symposium. It's a really significant day for Maddie Rebolt's Visions. We've had a lot of really significant days over the course of the last 5 years. As you know, Maddie Rebolt's Vision was set up really as a legacy piece to my late sister Maddie. I know Mum and Dad are on here as well at the moment, and we initially set out with a determination to put bone marrow failure syndromes on the map. It was obviously quite a scary period to go through as a family, incredibly, I think, under-resourced as an illness in terms of what actually backed it from a not-for-profit perspective. So we had a determination to fill that void, specifically with research, medical research projects that would create better outcomes for all of the people diagnosed and living with bone marrow failure, and better outcomes for their family members. And so in that 5-year period, we've really deliberately focused on medical research, but today marks an expansion into another really significant area. And when Maddie was initially diagnosed, there was little to no information about bone marrow failure for families, and in terms of the support networks that were available as well, that was an area where there wasn't a lot that actually existed. So Mum in particular, Mum and Dad have always been quite on our case, David and Nikki and the board, to expand, spend some of our time and energy into actually supporting people that are going through what we experience. So we felt quite lonely throughout that experience at times, and I hope now that on the back of what has been put together today and what exists in the form of Maddie Rebolt's Vision, that those of you that are going through something similar feel more supported, feel more educated, which after today I'm sure is going to be the case. So we've been able to honour something in the establishment of Maddie Rebolt's Vision that was really important to Maddie. She wanted to be an advocate for this cause. Clearly, she hasn't been able to take up that fight herself, but we've been able to do that in her honour. And also, really importantly, we've been able to honour something that was really important, that is really important to mum and dad. And I know there are lots of parents just like them that are joining us today, and we really just want to wish you all the best, to you and your loved ones. This is the first of we hope, many future forums where we can connect and learn, embrace each other. We hope we're able to do it face to face. I think anyone that knows our family knows that we're really tactile people, so we would enjoy the opportunity to be able to give hugs, to be able to embrace all of you, face to face rather than through a screen. But these future forums, together with our telehealth nurse Mei Ling, we're really hoping to be able to build and strengthen this bone marrow failure community, so that we all have access to information that's easy to digest, and also that emotional, compassionate element as well. So thank you all for attending. Big love to all of you. We hope you're hanging in there. It's a really tough period to go through this, particularly given the current circumstance as well. That creates an extra layer of challenge that I'm sure everyone is finding hard to navigate. But we're here with you. And lastly, to Professor Ritchie, David, we've been through a lot together. As I'd like to say, friends now. I genuinely mean that. You were with Maddie, step by step, side by side, the whole way through her illness. We know you did absolutely everything in your power to create a better outcome for Maddie. But your duty could have stopped there and then, but it hasn't. You've continued to work tirelessly over the last 5 years in an area that I know you're extremely determined and passionate about. So thank you again for your ongoing contribution for today, and to you and the subcommittee that has put all of this together, chaired by Dr. Lucy Fox. I can see you there, Lucy. Thank you very, very much. Again, this is just another layer that it might not get us towards the outcome of better treatments and all that any sooner, but the comfort that this will provide people like us that went through it, people like Brenda. I've heard your story, Brenda. It's just so compelling. We hope that this really does fill the void for people like that. So thank you, David. Thank you, Lucy. Thank you, Simon, for all of the work you've done in bringing this together, and to Nikki Long, the CEO of Maddie's Vision, and the executive team, Lou, Maggie, Annabelle. Again, your work across this space has been tireless. To all of the presenters as well today, thank you so much. This is still an area that's after 5 years of Maddie's illness, 7 months in intensive care, and 5 years since we lost Maddie, working in this space that I'm still incredibly naive about. So to listen to you guys speak, to hear hear about the work that you're doing, the passion that you have for your work, I guess it fills us with not a satisfaction. Satisfaction is the wrong word, but I guess the comfort that what we're doing and all the work that we're doing is actually achieving something in this field, which is ultimately why we started Maddie Reebok's Vision. So, we started it to change people's lives. I know Maddie would be incredibly proud of all the work that's being done in her name. Maddie had a pretty healthy ego, so she would really love the fact that her name has been able to instigate real change in this space. So, from Maddie, from my family, from my brother, Mum and Dad, thank you all very much for attending. Thank you all very much for contributing, and we hope you got a lot out of it, and we hope to do it again soon. So thank you.
Thanks, Nick, and just again reflecting the comments that have come through the Q&A tab. Everyone recognises the incredible generosity and compassion of the Rewalk family. Joe, Fiona, Alex, and yourself really started this journey for us all. And of course, just a few steps ahead of that, Maddie herself. And it's a huge honour to help bring Maddie's vision to the people of Australia and many of the people who are on the call. And thank you for your incredibly generous words. All of the people who are involved in setting up today, Lucy, of course, Simon, executive team, Nikki, bringing all of this together, our sponsors, of course, Royal Melbourne Hospital Foundation and Carmen's, yeah, they provide that sponsorship willingly, knowing how impactful this research and impactful these sorts of sessions are, knowing that they in some way can make a small difference to such a hugely demanding area of, and as Nick has said, historically underfunded and under-realised and under-recognised. I did want to spend just 1 second also thanking Erin Turner from the VCCC comms team, who provided a lot of technical support for today's session. As Nick has said, we would all prefer to meet face to face. This has really been a very fulfilling, but still a little unsatisfactory that we're not all physically in the room together to shake each other's hand, give each other a hug and provide that physical support. But I hope that people have found it useful. I'm looking at the participants. Many people have had to sign off, but we're still around about the 100 participant mark, which is really fantastic for what has been a very full day. I think that largely covers all of the business. Unfortunately, we won't have time for more conversation, and that's another thing that we can do in a face-to-face arena, is have those conversations offline in the tea breaks after the sessions and so on, and we look forward to being able to deliver that in subsequent patient and family fora. But it really just leaves me to thank everybody. I apologise that we haven't got to all of the questions. We've largely covered most of them. Some I've answered by written answers as we've been talking. And I really want to thank all of the participants, all of the families, all of the patients, those patients who are with us and those patients who are not, for their bravery and determination and the motivation to make a difference in bone marrow failure syndrome. And as I said at the beginning of the session, you know, we're all here for the same reason. We're all here because we want to make a difference and do things better. I also said that we had the opportunity to learn from each other, and I think we have, and we'll continue to do so. So I think probably best to sign off. Thank you, everybody, for your generosity of time and patience and wisdom and bravery, and we will hopefully see you again soon. Okay, thanks everyone.